this meeting back to order. John, if you want to go ahead and continue on with your team from where you left off, you're recognized.
So we're on slide 20.
Folks, yeah, thank you.
And we're gonna go as quickly as possible. But I also want to just reiterate from this afternoon, during lunch hour, we spoke to DHS, Mark Story, and Director Seelig and his staff. Stephen is going to work with them after this meeting. We're going to get you the updated spreadsheet on the impact, and it will have the general fund amounts and everything together, so you can send out, Mr. Chairman, to the entire task force before the March 7th meeting. I want to get it to you as soon as possible. So now we're talking about the nursing home issue and the levels of care. Now, there is, again, I want to say there's dispute on these numbers. I understand. I just wanted you to see this is what the data it tells us. If you look at number 26 here on the right, that's your lower level 3 tier. And we believe, and I want to compliment and also thank Craig Cloud, the Director of Aging Services, for helping us with his staff, his great staff. And you know, I think everybody would agree there's a certain segment of that population in there that could be transitioned into the community. And that's sort of where the nursing homes plan comes in, is to really work towards identifying good quality care and transitioning that population to a community setting at much less cost. So I wanted you to see that. If you look at, you can see the big difference in both years, 14 and 15 in the next slide. Very significant number of individuals that could, with the proper supports, be in the community today. And I don't think there's any doubt in that. And that's what kind of leads up to their recommendation. And we reviewed the recommendation, and also they worked with the department. So, yes, Senator, did you have a question?
Yeah, I must have missed something, because explain to me again on that chart there what we're looking at here. What is
so what you're looking at here is if we go back to, when you look at these are the levels, intermediate level, the level 24, for example, I believe is intermediate level 2. The 22 is level 1. 20 is skilled. So these are your real high needs. And then when you get to 26, that's your lowest level of need inside the nursing home. That's a resident of the nursing home. And so that level of care, I have the actual designation. It is, you know, they call them, so it's right here, it's 3-C for some reason. You must require total dependence or extensive assistance in one area of limited assistance in two areas, or have a diagnosis of Alzheimer or related dementia and require substantial supervision. So that would be your level 3. And when you look
from left to right, 20, 22, 24, 26, which one of those?
26 is your level 3.
Which means they need the most care?
No, lowest level of care.
But 20 needs the most care.
20 needs the most care.
And then what's the 70, 72, 74, 76?
Those are other cares that Craig can answer that. It's a very small amount of the population.
Okay, thank you.
But it's not, it wasn't something we focused on.
Okay.
But really, the designation inside the nursing homes, the nurses make the determinations from 20 to 26, and on a Form 703 that goes to the department, and then the department looks at it, the nurses, and they actually log and designate the actual intermediate level. So again, it's just showing you data that exists currently in the department that really tells us that there's a significant amount that possibly could live, again, with the right supports in a community setting. So the plan that the nursing home industry gave to the governor to meet the $250 million, we really scrutinized and looked at. It's what they called smart rebalancing. There are 3 tiered levels of care. They have accepted the fact that the Tennessee model that we've been talking to them about for a while, 10 care model, which has really significantly improved that whole area of rebalancing, they accept that model. They believe that those 3 tier levels are appropriate. They want to work with the department to modify and change the plan, state plan, and waivers. And they also agreed to an independent assessment. What they agreed to, though, on the independent assessment is it's independent for the levels 2 and 3. The prevention level 3 would be a new level of care. It's a level that actually, I was involved in the state of Rhode Island that we put a prevention level in to help those seniors that are just on the bridge of possibly being in nursing home level, but just need some small amount of help. And those individuals that are eligible would get a certain amount. And then the level 2 would be most of your home care, community. And then your serious level 3 would be nursing facility. The nursing facilities would still do the independent assessments for the highest level, that it's pretty obvious that these individuals need that type of care. And I think that we're okay with that, and obviously this would have to pass CMS muster, but it really changes the dynamic. You now have state nurses, which you don't have today, that are actually going to be doing the level of care determinations for a significant number of the population. And that's why that number that I showed you, the 7,000, is important, because going forward, a lot of those individuals are going to be in the area where state nurses are going to be intervening, either in hospitals, through their employees they have, they call it their A+ team, and they're going to work with the nursing home administration as well, industry, and it's going to hopefully be one partnership to really focus on, again, this is the key issue, right place, right service, right time, right setting. So that's really the key to all of this. So the nursing home would focus a lot on the transition planning. What does that mean? Individuals that are inside a nursing home. After an emergency room or after a hospital visit, they go to the nursing home. Transition is transitioning them out. The state nurses would focus on diversion, keeping them from going into a nursing home setting to the extent that they can.
We got a couple questions here before you get too much further along. Senator Ingram, you're recognized.
John, referring to Tennessee on the rebalancing, what level are they? Are they 50-50 or?
Richard actually just spoke to their director, so he knows the exact numbers, but it's significant.
In 2010, when they started, based on the new law that was passed in 2008, they were about 94-95% nursing homes. Now they're in the rest community. Now they're down to about 62-63% nursing facilities in the space of the last 4 or 5 years. And the trend is still towards 50-50.
And remind me, were we 70-30?
You were closer to 60-40.
535.
And based on your recommendations, what would those projections on rebalancing be?
We actually, in our recommendation, we were at a 50-50 by 2021, which would get you in the mid-9,000 numbers for nursing home residents. And I think the nursing home is absolutely, it appears in their plan that they would support that, because what they want to do is, but then you got to look at acuity levels, and those that are in the nursing homes are going to have higher acuity. You're going to have to adjust the payment rates as well. And so the one thing they're also agreeing to is on the $250 million savings that they would agree to a 5% holdback, and it could be a trigger. And we are recommending that they also be a gain share in there too. If they do a really good job, there ought to be some gain share on some of the savings. So that's part of our plan here. The other area is
I've
really...
got one more question for you. Senator Cooper, you got a question? You're recognized.
Thank you, Mr. Chair. When you talk about the assessments, independent assessments, really you're also meaning universal assessment, right?
Yes,
Yeah, thank you.
standardized,
Yeah,
yes.
thanks.
And that's
Thank
a
you.
really important point,
Yeah,
Senator.
thank you.
And understand, in the managed fee-for-service entity, and here's where it'll be different. In this particular area, if the nursing home is doing the assessments for the higher end, the managed fee-for-service entity would be doing the independent assessments in our Diamond Care risk plan analysis, but the nurses for the state would actually be doing the independent assessments in this case. Versus behavioral health and development disability, there would be companies that run the managed fee-for-service entities that would be doing the assessments. So this is a little different in this one, but it's the same principle, independent assessment, independent from the nursing home. So we are going to find a model for you and show you the number of state employees that would be needed, because we have to adjust those costs. Again, the plan that they submitted to us is attached as an exhibit. You have that. You can look at it. A lot of what I have in here, a 3 to 5% withhold, and that can be worked out with the department. you know, I was talking to Don Steele at the break, and the question is whether or not CMS would approve, or you could actually, not CMS, but you could actually do this in a contract without possibly some of the folks, you know, having some argument that you're affecting their rates. And so there's some things that have to be worked out here. But you could put this, I believe strongly, if you decide to put this in state law, that you could put that trigger as part of state statute. And then you could modify it and watch it. And you could also have a state law that basically says, if you don't meet the savings projections, that you move to a capitated full risk model. I mean, you could also have that trigger as well. I'm convinced, though, that they are very committed to making this work. I mean, we met with them, we felt very comfortable. The plan is well thought out, but there are things that still need to be worked out, so we'll have to continue to monitor it.
So members, for everybody's reference, E5 is the appendix, the actual plan that he's talking about there. It's in our packet. And I guess what you're telling us, though, is you're confident that this would really produce $250 million in 5 years?
I'm confident that that's going to produce the $250 million after talking to the industry because of the lever and the holdback and the risk. And this is what Representative Collins was trying to mention early on about Diamond Care. Diamond Care didn't have the risk component. This has the risk component. That's what's going to get you the savings. So I'm confident that you'll get your savings with here's where the only concern that I think I have, or our team has, is that, and I've talked to Director Cloud about this, there's savings that have to happen with regard to the department doing certain things. They've got to make sure they do an efficient job on assessments. The nurses have to do up to 3 assessments a day. They have to streamline that assessment process on the home and community-based system. They have to look at the home and community-based waivers. They have to streamline the waivers so that you don't get more than what you need on the waiver population. So part of this whole plan also includes a DHS component that has to work here. And so you're holding the nursing homes accountable for potentially something that may not work over the DHS area. And so we have to account for that. And I hope I've answered your question. I just don't want to make it sound like this is all on their you know, on their end of the bargain.
Would it require DHS having additional staff to implement all this?
Yes, and we've recommended that here. Yes.
Like how many additional?
I've talked to Director Cloud. He believes that 10 more nurses and additional staff for his A team, which are the ones that would go into the nursing home, not nursing home, but the hospitals and into homes when there's an intensive need to see if someone can stay in the community. The home and community-based providers, the AAAs and the providers that provide great care, they would also be very much a part of this because they're going to see an expanded population. And there's going to need to be some capacity issues, and there's going to need to be potentially looking at some of those rates.
How would this compare then when if we implement something like this on our per member per month cost versus national average, other states, and so on?
I mean, we just talked about the Tennessee model. You would be getting your institutional population down, and the per member cost would come back to maybe in the average. You would make a significant dent if you were able to accomplish this.
Okay, thanks.
And again, the last line here is important. Enhance focus on diversion strategy and on home care front, and strengthen the provider credentials and the level of services. So what we're getting at here then is you have 3 different actually 4 different areas. So you've got your development disability in your managed fee-for-service ASO structure, non-HDC. You've got your behavioral health in a managed fee-for-service structure. Then you've got your nursing homes, which would be handling on their own their risk-based model, working with DHS. And then you've got that high-cost population that would also be managed by that entity, managed fee-for-service entity. So these strategies, in assessing the Diamond Care with risk, I'm calling it, you're looking at the strategies are here. And what I added to this was, the first thing I want to mention, HDC. We talked about this earlier. We think that, and I know Senator Raper had brought this up in the past, to have a committee or a group of the task force get together and look at the HDC component. Because there could be savings there, but you got to make sure you also look at the quality of life, transition issues. There's a lot of issues, and they need to be vetted and reviewed. Quite frankly, I think that should be part of the recommendation.
Okay. Senator Rapert, you're recognized.
Mr. Chairman, to that point, we have discussed, and as you know, that was brought up right at the end of our proceedings last year, when the report was finally released. We need to think about going ahead and forming that. The governor's office has engaged, and I've met with, with their staff, John Martin and others, and I know that there's a commitment there that we need to fulfill. So I don't know at some point if we want to go ahead and form a subgroup. What is our end date for this task force coming up to the session? What is our end date?
December of this year.
Well, we have plenty of time then. I think within this structure, I think it should be handled within the structure so that we can continue to work. Everybody
Sounds to
here.
me like you're volunteering.
Well, I
And that's
think I got
good.
volunteered last year, but
Let me visit with the co-chair. We will ask, and if you want to be on that, let Representative Collins or myself know, because I agree, we need to get 4 or 5 members agree to go out and do that assessment, because while it's somewhat a political hot potato, it has to be looked at, both what we need to do for cost savings and what we need to do for quality improvement. So we will put together a subgroup, and we'll begin that process.
there's several members, I think, House and Senate, that have articulated to me that they want to do something in that regard, want to look at it, and are concerned. So I think maybe we put that on our agenda coming up here pretty soon, and let's get that in action so we
Yep.
can begin to work.
Okay,
Thank
and
you.
again, members of the task force, if you want to serve on that, let Representative Collins or myself know.
And what I would recommend, Senator, is like we have done with the DRG committee with Representative Farrar and his committee and Senator Ingram, we could provide the technical assistance, facilitate, get you the data, and help you. So, we'll coordinate that for you.
Okay, great, thanks.
And then prescription drugs, Rory is here to talk about the prescription drug area. Then we've got the dental issues, and you've got expanded PCMH, and those are the areas that, if you look at this whole plan, we've included those. Those were also included in Diamond Care. So it's not just the managed fee-for-service, it's these other savings items. So when we give you the cost projections here, we're talking about all of those items, okay? So what's important is to know, again, where we're going to be on the savings. So the model has certain considerations. Again, we talked about the linkage. The managed fee-for-service entity would have linkage to the PCMH. And that should be part of a contractual requirement. And I know in the nursing home area, they're looking at health homes, coordinated health homes, and Department of Human Service would work with them on that as well. We think there needs to be risk, and that for this to work, when we give you the model on the savings here, there are a number of assumptions. For this to work, there's got to be risk. And the risk has to be pretty much across the board, in our opinion. So you have the entity that bears risk, and we looked at a number of states. Some states do a holdback, some states do what's called the pseudo-capitation. They tie a PM payment. There are a number of ways. You do that in the contracting. And then the entity would bear a risk. In some states, we've seen, certain percentage of their administrative costs held back, or liquidated damages, or whatever it is, if you don't meet 2 things, benchmark savings and quality. And that all can be put into the contract. So you can put in the statute in the law that you want that in the contract. Let DHS determine the specific terms. But there's got to be risk. And then here's where it's going to get a little dicey. We think the providers have to bear risk here. And I've said this from the very beginning from our group when we came to you. Some may think they don't get paid enough. We understand that. But unless there's risk to meet benchmark savings and quality, this doesn't work, in our opinion. So what that means is that providers may have a holdback, and there may be something the department comes to you requiring some type of funds being returned, or something that gives them the incentive to meet the targeted savings and benchmark. Because the governor has a certain amount of savings he wants to be met, asked us to evaluate. The only way we're going to put a stamp that we think that can be approved is if you have that risk component. What I would also say, we feel strongly about, is that you put a gain share in there as well. If they do well in enhancing quality, if they really start showing the trend coming down and things are working effectively, in relation, it's not just population growth, you have to consider that, then they should be rewarded. And so you can do the same thing, so it's not just all about risk, it's about reward, and that's a really important thing, because it makes the whole managed Medicaid program working in partnership to what? Enhance the quality of care for the patient. So that's a really important thing. The other, last thing is state plan. You're going to need state plan waiver, rules, changes, and some of them are going to come to your, if you pass this, some of them are going to come to your rulemaking bodies very soon, especially in the behavioral health area, because I know they're starting to work on that. So those are areas you're going to start seeing. So, I mean, things are starting to really percolate to becoming action. The one thing, also, before I get into the projections, we have not projected out or put savings for what we call centers of excellence. Stephen and I have met with UAMS, and we met with a couple other providers. We met with Children's Hospital. We think that there's a really good possibility here that there could be a recommendation that adopts some type of center of excellence for neonatal care and certain cancers that could bring additional significant savings. And we want to be able to model that in the next few weeks for you. But I think a centers of excellence concept might be something you want to pilot in this whole program.
Okay, we got a question. Senator Irvin, you're recognized for a question.
Yeah, just in the discussion of that, I know in my research and reading through healthcare journals and studies and policy, papers on this concept, that there's a strong move to get rid of the any willing provider laws that exist on the books to allow for something like this. So could you give me your understanding and take on that? Are you promoting a change to that current state law of any willing provider, or how would this?
Yeah. No,
I guess I have a little
it's a
bit
good
further
question.
questions
It's
because
yeah.
you're talking about government really directing outside of the private businesses and private providers, and I'm concerned about that.
Yes, and I share your concern. However, I think that's why we limited it to very limited areas. For example, you have a cancer center here that's nationally recognized for certain cancer treatments. You have misdiagnosis that we have been told is occurring at substantial alarming rates, and you have certain areas that could provide good care, and you could direct without giving up that freedom of choice. And the key is any willing provider and freedom of choice still is not impacted by this. And the CMS would not, you'd have to get a waiver of freedom of choice. So we're not talking about that. But we're talking about directing in a more care-coordinated fashion for those particular areas that right now in your budget are significant and could be controlled much easier than some of these other areas. Again, it's a concept that we want to explore further, but share your concern.
Okay,
And
thank you.
competition is also one that we agree with.
Right. I have great pause and hesitation about this concept because of that dynamic in place, so.
Share your concern. We have not modeled savings yet because we want to do some further analysis for you.
Okay, thank you.
When we look at the savings and the modeling, the timeline here is really important. I want to be careful that you recognize timing is important. You've got to give the department time to implement a managed fee-for-service system. You've got to give them time to, if it's capitated managed care, you have to give them time to do that. They have to write the RFPs. They have to have CMS approval. They have to have stakeholder involvement. There's a number of months that have to go on. They've got to make sure that the environment is ready for this. And if they're given the go-ahead, we put certain, I would say, assumptions in our timeline savings that might not be entirely the way this ends up. Because you may have rules here, and you may have other issues that hold up the process here in Arkansas. Things take a lot longer in these areas than other states. So we're trying our best, and I'm going to say right now, this is a very aggressive timeline. So if you want to adjust some of the numbers, that's fine. But we're giving you a very aggressive timeline because we feel there needs to be action. And we hope that the legislative body would trust the department and be able to let them get some of their rules through a lot quicker, and things would start to happen. recognizing you're going to have a lot of providers that are going to have concerns. So basically, if you think about it from a number of areas, baseline projections, state fiscal year 17 to 21 is the 5-year time period. We looked at most programs starting in January of 2017. Now, that means that this year, like for example, let's use behavioral health. They'll start putting together rule changes. They'll start changing RSPMI. They'll start working together on a plan. They'll come forward. But nothing in the rule changes that are being made will take place till January of 17. Then we have to account for, that's 6 months of your fiscal year. So we have to discount the savings by 50%. That's what that means. In capitated managed care, we're giving it even longer period of time and saying capitated managed care, if we went down that road, wouldn't happen until January of 2018. So you've got to take into consideration there's a lot of time that's needed. Now, a managed fee-for-service entity would probably be up and running in July, I believe it's July, or did we say January of 17? Between 17 and July and January, that's what it is. So we struggled, how much time is it going to take to get a RFP out and to have the managed fee-for-service entity start? So in the behavioral health and the DD savings, I think we started at July of 2017. And you give them about 18 months from this day, or a little less than that. But that's a significant amount of time, but believe it or not, that's an aggressive timeline to put out an RFP to move forward. All of this I'm telling you is because the longer we wait, the less and less it is you're going to reach the savings. That's all.
So would you just summarize that timetable again, compare what we're talking about here, managed fee-for-service versus managed care, as far as when the savings would begin, when they would begin
Yeah.
full implementation?
So you're going to see in the model when we start showing you some of the numbers, and I'll go over each line to try to make it clear, but in a nutshell, I want you to think about without managed fee-for-service, put that aside for a minute, there are going to be some rule changes that will happen in either area. There are going to be things that are going to come to you soon. And we're saying that the rule changes should be in place by January of 17. That's going to start savings accruing. We're saying the managed fee-for-service entity really won't be up and running until about July of 17. So that's more than a year from now. Gives them time to put the RFP together, work on. If it's capitated managed care model, got to give it another 6 months. I mean, there's got to be time to really, before they go live, because you're dealing with building networks. You're dealing with other issues. So that starts January of 18. Those are the timelines we used.
Okay. Senator Sanders, you're recognized.
John, have you, in looking at those timelines, have you accounted for all the public comment period, all those aspects of, I mean, because, you know, we've got our regulatory process. Oftentimes you'll see some of these will go to the health committee before they come to rules and regs. Then the governor also has a process that an additional process that he has put in place before it goes to the legislative branch. So I think obviously timing is critical. I just want to make sure that we're all very realistic about the time frame that we're looking at.
I mean, I'm going to let Stephen answer that. I said we're aggressive, and it's probably a little more aggressive than you could probably do in reality.
It's interesting. I was just talking with a couple of our representatives in the back and senators. You know, we're obviously going to probably have to have some special meetings for some of these changes. But there are some things that we could pile up meetings, back-to-back meetings, all we want. But there's some things that we're going to have to deal with in terms of the comment period, having a public comment
Yes.
period, and dealing with those. And if there are any changes that come as a result of the public comment period, and I think, as you're all aware, that there are a lot of people in this room that will have plenty of things to say about any rule changes. So.
If you look at the traditional managed care rollout in states, we've said that it's about 18 months to 2 years. So that's just the average of what most states rollout period. In managed fee-for-service, you're not dealing with credentialing the network. You're not changing a lot of the things that take a lot of time, but you still have to have those stakeholder meetings. You still have to have the rules. So we discounted that back about 6 months.
Okay.
Again, it'll just change the savings numbers.
Right.
And more generally, On these, because the particular set of things like public comment periods, CMS negotiations, et cetera, that would be involved will depend on the details of what actually get decided. We couldn't really put together an exact lineup like that.
Okay, as we get closer, I think we need that, we're gonna need that
Yes.
map anyway. I mean,
Yes.
we'll have our staff work, and you can work with our legislative staff
In
to
part,
do that.
we recommended in the report that DHS put together a very detailed project plan on all these with timelines, milestones, and deliverables.
Yeah, all right, thanks.
So, and we'll be monitoring that.
Oh, we got one more. Senator Irvin.
Yeah, on that conversation that was going on, I just want to point out that there is good reason for those different steps. And there is good reason why things were sent to the ballot and the people of the state of Arkansas voted on transparency and accountability in that regulatory process, because we don't, and I think it's worth noting that yes, it may take some time, but it's because of the public integrity of what we're doing versus state law. I'm sorry, I just needed to add that. Thank you.
And thank you for that point. So the baseline we used on the spending here is contained, these are the 5 years. And basically, we brought the slide you had last time in terms of the total budget impact. At the end of the 5-year period, if you do a 5% growth, looking at all these programs in your Medicaid traditional budget, you're going to be a $29.7 billion spend. That's basically what this is telling you. So just keep that number in mind on baseline. And you can look at these closely if you have any questions. Now this is managed fee-for-service. So this is your MFFS is managed fee-for-service. So if you look at the first line, and these are numbers that we put together, and Stephen, if you want to go through the detail of the spreadsheet, that would be helpful. I'm going to hit just the high level. Again, I said this earlier, nursing home is the second line, 163 million. Yes, they have agreed to 250 million. This is where you can see that the state has a piece of this important factor too, where the state has to meet certain savings in the community-based programs, and that's an $88 million estimate. Again, all these numbers are estimates, and what I didn't say, it's in the report, we looked at so many states, and we tried to, at the end of the day, do the best we can to give you a ballpark percentage savings based upon what we've seen in all these states. And it doesn't mean it's going to happen here. That's why we use the word estimate. And it's our best guess that we can give you right now. Stephen?
Okay, we got a question here. Representative Boyd, you recognize?
Thank you, Mr. Chair. Can we go back to the last slide? Okay. Can we go over those? I mean, I'm not sure those numbers look right to me. And so maybe I'm missing an overall component, but specifically all prescription drugs
Stephen?
What is the question?
I don't think that I've never seen prescription drugs add up to that number, and so I'm questioning whether or not that's correct. I want you to help me understand what went into those numbers so that I can make it all add up. Because is it a rounding error, or is it really that big of a number? So that's what I'm trying to clarify.
There's a growth factor in this, and then also that's the 5-year total.
Okay.
So remember, the
What
Halo,
percentage growth? I mean, it's been growing at 0.1%. I mean, I'm just still struggling with how you got $2 billion on the drug. So how many years are we talking about? And let's make sure this is a real number before we start hanging our hat on it's 29,722.
Yeah, so we applied the 5% growth factor that the agency has historically applied to Medicaid growth projections to each line independently.
Okay, so that is based on 5% growth, not our current historical trend.
Our historical trend or the historical numbers have been anywhere between 10% year on year and 2% year on year. But the agency has.
For the total budget,
For the total budget, correct.
but not specifically prescription drugs.
In this, we just applied that same growth factor across the board.
So that's true across all of them, not just prescription drugs. So we're
Correct.
assuming all of those would grow at 5% regardless. So some of them might have grown at 10. And so when we're looking at, we're going to break this down and we're going to hold everybody accountable, whether we have managed care or we have managed fee for service, we're going to just assume everybody has 5% growth.
For the baseline, that is the assumption that we made.
Okay? Just thanks for the
Yeah.
clarification.
And also, when we get to prescription drugs, there's a certain amount of savings we've connected to prescription drugs, which are specific dollar savings based upon specific plans, that you know about the different recommendations. So the savings actually are not just based upon a certain percentage of savings, they're actual savings numbers. So, and Roy will explain that. So the generic difference is about $19 million a year savings. I mean, so the savings are real numbers.
And I guess to Representative Boyd's point, he makes a great point, but it's far better to be overestimated on growth when you start having a savings number calculated than underestimated. So actually, I'd rather be where you all are than somebody who was doing 10% and we're going to base the savings number off 5%.
Yeah, and we had talked about this the last meeting using the 5% benchmark, so we could have gone to each individual line item, but it's pretty consistent. And if you look at prescription drugs, we can come back next meeting and show you what that's been historically. So these savings numbers come off of, again, you look at the baseline, and we looked at historical spending, and we put the 5% factor in there. And the good news is most of the industries, the development disability groups, the nursing home, and even the behavioral health didn't give a targeted number, but most of them have given a targeted number of where they agree to in terms of savings. In the development disability area, they agreed to somewhere around $198 million. So when we looked at a 5% growth, we put their savings number in there and tried to figure out, and it compared very closely to the numbers that we used from Louisiana that were in our October report. So when we look at the savings calculation here, so you see $88 million on the community-based care line, $163 million on the nursing home line, and then the development disability, $193 million. And the behavioral health program, it was a little different because we didn't get a number from them. We got a number from the development disability providers, which is that number basically. They gave us some additional savings that we didn't use, that we can also look at later, but we didn't feel that those savings there was enough detail and information, and we needed to dig. But the 193 was pretty much their number. So the 261, though, we did, and I'm going to say it was an estimate. We all got together, our best estimate, we thought, can you save 10% off of the line item on behavioral health? We looked at what OMEG's going to report to you on just the one group, the psychotherapy line, that they're going to work towards changing rates. There's going to be some other issues. We saw that amount per year and felt that a 10% amount was probably reasonable in your state. Then we looked at the state of Virginia. Virginia, they have a managed fee-for-service entity that handles the behavioral health spend, and their savings in the last 2 years was 9% a year. Now, that was not counting admin. So their admin was probably going to discount about 2 to 3% on admin. So again, we looked at Massachusetts and a couple other states. So you may disagree that 10% is not the number, but that's the number we used.
And to clarify, when we say 10%, we're talking about 10% off of a 5% growth rate.
Correct.
So, for instance, it goes from 490 to 560 over the 5-year period because we're just really slowing the rate of increase.
That's what this is about, yes.
Okay.
And that's why that 5% factor was really important to get clarity around early on, because we were basing all of our savings estimates off that growth factor. So you can see the managed fee-for-service is about, the model comes down to about $700 million in savings over 5 years. Now, that's very close to what we had in our October report from just using the Louisiana amount, and that was somewhere around $700 plus million, 705 or 750, I'm not sure, but it's very close. So the providers have come forward and actually gave us recommendations on dollar amounts that are pretty good. So, but that doesn't account for everything. That's why I said pharmacy. There's other areas you have to look at. So the next thing is all prescription drugs. Rory can address this. Rory and the department are working, and they believe that you're going to have $160 million of savings based upon the changes that are going to be coming forward in pharmacy. And I think Representative Boyd agreed to those issues too, and in your experience, others. So that's a number, and Rory's here if you want any explanation. That's a number that we feel really good about, and you, the task force, should feel good about that. Because a lot of that was Rory working with the department, and those numbers are going to be we're pretty confident that you're going to get those numbers. And one of them, I'm going to have Rory explain, is a drug that's going from brand to generic. One drug accounts for somewhere around $18 to $19 million.
One additional comment on the pharmacy savings is 2 of the 5 components to the savings number, the 32.5 million annual savings number, 2 of the 5 components are actually going to be in place during early calendar year 16. So you'll start to see those savings prior to the timeline that John laid out with implementation of either managed fee-for-service or fully capitated managed care.
So we are confident that the $32 million is real and that we will begin to achieve some of those savings in the next few months.
Yes.
And you said that changing, I guess what I struggle with is, why did we not buy the generic drug a long time ago?
The generic drug wasn't available until the brand name patent expired.
So when did that happen?
It happened in April of 2015, and then it takes about 9 months for generic manufacturers to enter the market, prices to fall, and for prescriptions to be converted with existing users.
So are we taking credit for something that would have happened anyway, or is this happening because you guys are asking the questions?
Some of each. So the techniques to ensure that claims for the brand are not paid, not reimbursed, and people are switched to generic are initiatives that the department has to undertake. But yes, we didn't do anything special to make the drug the brand name drug to lose its patent.
Do we have a process to ensure that as those patents expire, we don't sit there and continue to buy a brand name in place?
I believe you do, yes.
Okay. Representative Boyd, you recognize? Oh, okay. Go ahead.
All set. And then, so what Rory is mentioning is there's other prescription drug savings. The brand name may be half of that amount. There are a number of other savings that he worked on with the department that he and the department feel very confident are going to materialize. I also want to thank the Pharmacy Association. I mean, they met a number of times. They gave us a lot of different thoughts, and they are willing to look at a holdback. They're willing to look at some risk, which I received an email from their director, and I was very impressed by. So, I mean, again, it just shows you that there's a lot of providers here that are trying to work together. Then the 20 million is dental. That was in the governor's plan. We didn't change that. One thing we would say with regard to dental, and we said it in our report, you may want to have requests that DHS, again, you don't do the RFP drafting. DHS is doing that. But you may want to make sure there's a provision in the contract that, allows the state to share back some of those savings that the dental managed care company makes. At the end of the day, your dental program could potentially have some significant savings if they do a good job and also increase access. But, there are states that in managed care have said, similar to medical loss ratio, there's only a certain amount of revenue, and then you're going to start sharing back with the state. And that's not something that we talked about earlier. We talked about gain share in specificity, but that's something the department should be thinking about when they structure this RFP. But that $20 million, industry feels confident, very confident can be met. The $213 million is additional savings in enhancing that PCMH model into this high-risk type population. And Stephen, you might want to address quickly why that number is 3.1%, because someone might have a question.
One of the main sources of data that we used for the cost savings for PCMH was the experience in Louisiana, where they ran a fee-for-service, a PCMH, and capitated managed care in parallel for a period, and were therefore able to do some pretty direct comparisons, risk-adjusted comparisons between the spend in the different categories. That combined with the fact that it is a neighboring state with a similar population in many ways, made it seem like a good set of comparisons, or a comparison site. What they found was the difference between their fee-for-service and PCMH programs was 6.38%. Because we have already been running a PCMH program here in Arkansas in a limited way, we felt like about half of that potential savings was probably already being captured, and that is consistent with the cost savings that have been attributed to the Arkansas PCMH program so far. And so with the strategy being to expand the PCMH program to its logical bounds, we thought that it was reasonable for that additional 3.19% savings to be captured.
So 392 million is additional savings over the 5-year period. So when you add that all up, you have to then account for the staff we talked about, Senator Hendren. You need some nursing staff. You also have a line item here where we eliminated staff. We felt that the department could reduce staff. There are development disability staff and other staff that the managed fee-for-service would take over the roles. And we accounted for that, and you can see that's in the first line. There's also a case management fee that's done by development disability case managers. The question is whether the managed fee-for-service entity would actually do the case management or subcontract that out to providers. And that might be something that still needs to be discussed with the department. We accounted for that savings. And then we had to account for the FTEs, because you're going to have extensive amount of FTE for the administration to help DHS do the right vendor management. This is a really important point. And we said this early on. McKinsey came in and gave them an idea that it would be about 25 to 45 employees needed in vendor management if you move to a capitated managed care model. And we've told you all along, you're going to have a really good contracting staff. You're going to have to have some legal help. You're going to have supervision. You have to have a whole new division handling just the contracts. And is it 45? We went on the high end. If you're doing a managed fee-for-service, I think you're probably going to need more administrative staff than if it's a capitated managed care. But I may be wrong. But we just ballparked it at the high end on the 45. And it could be more, and we probably want the department to let you know. Then there's additional nurses, and technology costs, you're going to have some additional technology costs. And they're going to be costs that are going to be based upon shifting some of those functions even to the managed fee-for-service entity, MMIS changes, a whole host of stuff. So we accounted for some of that. And what we came back down to was about $1 billion in savings. And this was almost where the target was that we were trying to look for in the beginning. How do we get to $1 billion to have that cushion? Because you have to have at least 835. We can feel confident if you adopt this structure, working with the providers, DHS working with the providers on the plans that you have submitted as exhibits, that you could reach those savings, again, off of growth, off of that 5% growth overall. So this is kind of where the savings are, and I know, Representative Boyd, this is not every individual line per se at whatever certain historical percentage. We could go back and do that, but I think you're going to be very close to this number based on what we've seen in the other line items. And the $28.6 billion is, again, savings off of a 5% growth. Any questions on this?
So when the governor used his calculations to come up with the 835 million, was he assuming an a 5% growth and a cutoff
Yes,
of that rate?
yes,
So we're being consistent with?
yes.
And so what you're saying, under this managed fee for service, rather than spending 29.7 billion, we'd send 28.6 billion?
Yes, and you actually haven't cut the program. You've reduced the level of growth. Now, there are going to be changes in rules and other areas that you have to account for, that somebody's not going to get what they've been getting in the past, because it may be overutilization or other issues, no question. That's what reform is all about. But this is not major reform. I want everyone to know. This is not major reform. To get to major reform, you've got to really look at a complete restructure in the waiver with a lot of flexibility, like the governor's talking about. Then you can talk about real structure reform. But this will put a foundation in place.
So this allows the program still to grow from 5.2 billion to 6.3 billion?
That's correct.
Senator Irvin, you recognize?
Just on that point, when you're talking about the major reform and the flexibility, you're referring to the global waiver
Yes.
model, correct?
Yes.
Okay, I just wanted to.
Yeah, and that's actually
I don't
in the
disagree
report.
with you, but I absolutely agree with that. I just wanted to make sure we were talking about today or tomorrow, you know, because
Yeah,
that's
and
not currently
It's
the.
a great question that Senator Irvin asks, because we've always recommended to move forward with one global waiver. The department, folks I've talked to in aging agree with that. Some in aging feel that you have personal care, and you have folks in the home care waiver, elder choice waiver, it's been changed now, the name, are also getting personal care. And the question is, you know, if you have a good assessment, you should get what you need, not what you want, and it should be good quality. And this is what, you know, you'll have a lot of flexibility, and you know, maybe a senior, and I said this before, falling down needs home modification. Maybe she needs railing or some home modification that's not in the waiver. And guess what? Because she's not in one siloed waiver, she doesn't get that, and she ends up in a nursing home. And that's what we're talking about here. So, yes, it's absolutely essential, but the problem is, they're already thinking about state plan changes. And, you know, you start making those smaller changes, when you have to really make one big change, you know, you gotta be careful how you administer that. I know the new director knows that well, so I'm sure that will be discussed.
This builds that basis,
Yeah,
what
the
you're saying.
foundation,
It builds the
correct.
foundation
Correct.
for leaping into
Yeah.
that global waiver situation.
Yes.
Okay, thank you for that clarification.
And then the projected savings, and I'm going to, now, this was Senator Dismain was here, and he wasn't here today, but last time he wanted the general fund savings, and I know he asked BLR to provide that, so this is actually addressing his question. The nursing, you can see, because the nursing home savings, because of their bed tax, and we worked with them on these issues and the department and tried to understand the entire methodology. Stephen did a great job working with this, but it's pretty clear the savings are a lot less in the nursing home area because of the bed tax when you get the general fund. So now what this slide does is gives you the general fund savings. So you can see where the home and community-based savings, the general fund is 26 million, and it's about the same, actually, but you're looking at a 16.27% effective state match in the nursing home area because of the bed tax. So, and I think that's what the senator was getting at when he was asking the question. So I know he's not here, but I want to make sure we had this for you, and you'll be able to, you know, identify where is the general fund going to go up and down in this whole plan.
So you're showing $300 million savings to the general fund over 5 years. So we would expect it to be a 70 million or so at the end of the period moving forward? General fund savings. Because again, as I look at what we started with, it was to try to figure out how to come up with our 10% match.
Yes.
And,
Oh, and then, the net,
Right.
net.
Right.
Yes. That's how, I'd like to look at the new numbers that we're working on with the department and come back to see if there's any impact change on the general fund component based on your question this morning.
okay. And Representative Boyd, did you have a question? Okay, push your deal there. Go ahead.
I hate to come back to prescription drugs. Let me preface this with, I'm not an attorney, I'm not an expert, I'm just a citizen legislator. So one of the challenges in the controlling the growth of any of the healthcare budget is unforeseen technology, things that come out, and then suddenly there are mandates that we have to pay for. So one of the unique things to me and the whole Medicaid prescription budget is it's not really a free market. There's a federal law that requires the Medicaid program to cover drugs if they're on the market, if you will. So that doesn't allow a certain level of the free market to occur, because if you got, say, an expensive hepatitis C drug and there's only one on the market, at some point you have to say, well, the patient meets the criteria and we have to pay for them. So the question, I guess, is somewhat legal in nature. When we're talking about these waivers, are there any opportunities to request being waived from that federal requirement?
Yes. I think I want to answer that with two areas. You always have the ability in a waiver to agree, it's like a contract negotiation, to a provision that says unforeseen circumstances due to economy, due to growth and unforeseen population growth. You can, and CMS has agreed to this in the past, that the waiver cap line that they've agreed to on a flexible type, 1115 global budget actually can be expanded. So if that's kind of what you're looking at in terms of your question, you're not stuck to that number if there's unforeseen circumstances.
To me, that's concerning, but it's easy for me as a pharmacist to talk about drugs because I deal with that every day. But quite frankly, there can be new scanning technology,
Yes.
there can be new diagnostic tests. But I know specifically in the drug market that there's a federal law that just says if it's out there, once they meet certain criteria, you don't have a choice but to pay for the drug. And they can basically charge whatever they want. So that is not something that the state can control without some level of waiver. So if there's a way to work with that, I would ask that this committee give that consideration to include any type of waiver.
I think it's a great idea. Roy, do you have anything to add to that? Because it's a really good idea, Representative Boyd.
Only that in the waiver construct, it should apply to all kind of revolutionary new technologies, not just, and drugs are an awesome example because in the pipeline, the near-term pipeline for drugs are very expensive new drugs for small populations, and you only have to have 1 or 2 or 3 of your Medicaid beneficiaries who need one of those drugs, and they could have big impact on the budget. But more broadly, same with new technologies beyond drugs.
Okay, thank you.
It's a really good question, because when you're negotiating a waiver like this, the global waiver, what we're talking about, even if you get down to the whole program, you're going to be in front of Office of Management and Budget in Washington, and then Baltimore CMS, and they're going to ask questions. They're going to try to hold the state line in terms of that growth. The state should come back and have what you just said. We want a provision in there that allows us to expand that top line so we're not held accountable if these particular costs go up in an unforeseen situation. Some of it mandated by your own regulations. But the good news is every year, CMS in a waiver every year in 1115, they'll look at it and they review the numbers with the actuaries and state staff, and they have to have reporting, and that's when it can happen every year. It can be readjusted. It's a great question.
We got a couple more here real quick. Senator Irvin, you recognize?
I apologize. It's a little bit along. It's with that slide, this one on page 35. So that is over a 5 year, is that correct?
Yes,
2017? Yes. Okay, that's all I needed to clarify. Thank you, sorry.
Yeah. So.
Oh, we got one more. Senator Cooper, you recognize?
Thank you, Mr. Chair. Back on the language that you just stated, I would say we need to be careful with the language there because we're not talking about just new technologies, we're talking about new uses possibly for old technologies. And there's been some of that in these drug markets.
Yep.
Thank you.
It's a good point. And again, all of this is important for the department who's going to be doing the negotiation. So.
Yeah, and I guess the only thing I would add is, and I remember some of these same discussions on our other task force with regard to prescription drugs and the federal requirements and laws that have made the program more expensive. And as you mentioned, federal waiver and the recommendation to come up with a global waiver, are you guys keeping track of all this stuff we want to put in that waiver?
Well, I mean, I'm writing down everything here. We've got, here's the bottom line.
gonna be
It's
pretty long.
DHS. It's DHS that does the waiver.
Or we could just say, let us do what we want, right?
Yeah. I know the department's here, Senator, so I'm sure they're listening.
I guess because I think we found ourselves in a situation where we've got 5 or 6 different waivers because we come up with these things and we go submit a waiver, and then a year later we come up with another one. So I guess if we're going to actually pursue a global waiver, we need to have, I would hope you guys pulling all the ones we have together now and
Yes.
incorporating them into one, and then adding all these things that we've been talking about for the last
Yes.
couple, yeah.
Yes, and we have some examples from other states, too, we can look at. But, for example, the tiered level, Tennessee tiered level of care, all of that is put into the waiver. So the agreements are all based upon how your program's going to be managed. The good news is you have a lot of flexibility in between that waiver to actually make sure the individual from the assessment gets what they need versus having to be in a different silo-based state plan, rule, or a waiver. And that's kind of what we're talking about here. So I think this is so we've gone through this. I know it's taken a while, but we've got to be at a point, in our opinion, where you have to make some decisions. And I think what I've tried to lay out for our team here is we're in a path where this is your managed fee-for-service. A lot of work's going to go into putting this together. Contracts, oversight, management, DHS changes, a lot of stuff. So then the question that the chair's asked is how to compare that to a capitated managed care model. So we stepped back as a group and we looked at this, and we kind of put together some thoughts for you. And this is not, again, this is up to you to look at, but again, this is all just looking at what other state experiences are. And someone said earlier, well, there's states that have not had similar experiences. That's correct. And a lot of it comes down to how you're going to manage this program and the staff you have to do the good job, to watch the MCO if you go down that road, to make sure you have proper utilization. But in an MCO environment, based on all of the other states we looked at, you can look at each individual line. I can go through each of them, but basically your community savings will be higher on a nursing home. The 163 stays the same, nursing facility, because in this particular proposal, we've exempted the nursing facilities from managed care. They have agreed to an $850 million savings, $250 million savings component, and we have exempted them from capitated managed care in this model. We could put them in and have greater savings. But we're giving you another model to look at based on the chairman's question that we think is a model for you to consider. This would have the community-based driving the community-based spending and savings into managed care. So you wouldn't have the nurses at the state. You wouldn't have all of the, intensive nursing home, emergency room work. Managed care companies cut their teeth on this. They go into the hospitals. They have coordinators. They really work. Or you can have Craig Cloud and his division hire 10 nurses and try to do the same thing the managed care does. But the bottom line is, in a capitated model, they're going to work their tails off because that's where they make some money. But yet, in your state with the bed tax, you still have to count there's going to be some, not as big general fund savings, which we showed you. The next line is not the nursing, but the DD costs. And that is including the HALO. So all of the medical costs that are associated, that we gave you those numbers early on, the HALO medical, because your managed care companies handle the medical costs. They coordinate the care and medical. They coordinate the network. So that's one of the reasons why they can have higher savings, because they do a lot with the networks and they do utilization. And some of the networks don't like them in states. And some of the doctors don't want to be involved in this because they have concerns. And some doctors we see in states don't have a problem with it. But they are going to save more from all the models we looked at. And then in the behavioral health space, you're going to get additional savings, because here's the bottom line in behavioral health. You're going to have a managed company that's at full risk. Again, this is full risk model that bears all the increased costs beyond your budget line are on their bottom line, not 100% on yours. That's the difference here. and they'll work with the network. So when you see this at the end, the best we could do, average, probably ballpark, $1.5 billion savings. And that's very consistent, again, with what we had said in our October report. That's after admin. We've already discounted for admin. So now you come down to, okay, you're going to reduce agency staffing because the company's going to be doing some of the work. You're going to end up looking at that case management fee again, being absorbed by the entity or subcontracted out. And then you have to add back what the state's going to need for admin. They need new oversight. They need new contract management. In that 45 position, McKinsey said 25 to 45. We put 45. But then the bottom line here is, and this is where, we as a group have looked at this a number of times, that $215 million is your premium tax. We've talked about this. That's your premium tax that you would get from the managed care entities. And it's just like the premium tax for private option, same statute. So you have to add that in the managed capitated model. You have to. So in this model, the governor said to you today, we want to fund the wait list, or we want to, those costs are substantial. If you want to fund the wait list, there's some opportunity here on a managed care premium tax. That's bottom line. But again, you have to hold their feet to the fire too. You have to make sure that the managed care companies, if you go down that road, in the contracting, that you have, for example, that MLR amount and that gain share back to the state provision and all of the best provisions that you have for contract management, should be in your contracts. So if you go down the road of capitated managed care, based on the chairman's question, that's our best estimate. Now, you can crack holes in some of these numbers, but they all compare to nationally what we have seen in most of these other states. And the bottom line is what I said earlier. It's not going to, you're not talking about dramatic reform in the sense of bending the curve. Again, we're talking about stemming the tide of growth. And these are the growth factors at 5%, 4%, 3%, 2%. The only reason I wanted to show you these is because if you start getting down to that 2% growth area, is where your tax base is, right around that, a little more than that amount, your tax revenue. So this is something Steve and I have been talking about. Where should we recommend you be? UAMS, and I have it here. If you remember, UAMS gave you their plan. And I'm reading from their plan. They said, the second goal we recommend is that healthcare cost growth not exceed GDP growth year over year. In general, this would mean that cost growth is equal to or less than 3% per year. And that was from UAMS. I think that's a good goal to have, and I think you can even do better. But that's the comparison right there. And it's not exact because that's estimates. And can answer any questions, but
Yeah, Steve, John, so if I look at page 31, in the non-capitated model, I get $1.057 billion in savings. And then if I look at page 37, I get $1.669 billion. So the difference is roughly $600 million between the two options. Am I reading that correctly?
yes, and the premium tax accounts for a significant amount of that difference, 215 million, yes.
Okay, and the plans have many of the similar elements between them, except the big difference is capitated full risk managed care and behavioral health and DD. Is that correct, or am I missing?
Slide 40 is, I think, the most significant differences. It's the risk. It's the risk, which is big. It's the more the networking, the credentialing, identifying And utilization, I'm not gonna sit here and say the utilization's not gonna be stronger in controls, and there's gonna be issues. But utilization control, and you're gonna have to, if you go down that road, you have to watch that closely as well. The one thing I would say is the admin amount is about 10, the Milliman report showed us between 8 and 10% admin, versus this managed fee-for-service admin is gonna be a lot lower, about 3, probably between 3 and 4%. So those are some of your differences. Slide 40 answers your question. Slide 39 are the key assumptions here that I think are critical. We talked a lot about them.
Before we go on, we got Representative Boyd's got a question. You recognize?
Okay, again, as Representative Collins likes to say, I'm in the slow learner group, okay? So with either proposal, are there guarantees? I mean, is there one way that we can just absolutely hang our hat on either number?
No.
So on the other, the managed care proposal where the number is higher, there is a possibility that no matter how well we write the RFP, no matter what we do, that we could still be like Florida and have the managed care companies come with their hand out and say, well, we thought we could do it for that, but we can't. Is that the case?
Yes.
Okay.
But there's
Thank you.
also, you could also be like Texas, that's really been doing a good job in terms of the finances and controlling that. You could be like other states. But again, you're absolutely right. So yeah, I mean, here's my concern though, is no matter what you do, you have to take into account the DHS is going to need the resources to make this work. And if the contracting's not done right on the managed care capitated, I would have concerns that your state's going to see a lot of the same things and problems that you're hearing about. So yeah, but you can account for that. Other states have.
Representative Meeks, you recognize?
Thank you, and it's kind of what Representative Boyd had said, is the fact that if we go with the one, then the state's at 100% risk, meaning that we could have to pump in hundreds of millions of dollars more that we weren't expecting. If we go with the MCO, there's a possibility that they could either come with their hands out, or they could cut provider rates, because in one of the talking points on page 40, it says they could negotiate rates up or down in value-based purchases. So am I guessing that they basically set the rates that they pay providers, and that providers could actually be the one that could get hit, or hospitals could get hit if things don't work out like we hope that they would?
And again, it's a good question. We had mentioned to you a while ago that in some states, they put in the contract that MCOs cannot cut rates based on what they are.
Right.
So, I mean, a lot of it comes down to how you manage the managed care companies. And do you have faith in your DHS to manage it well to where your expectations are? And in the managed fee-for-service, they're still going to have that type of administrative thinking, because you want to make sure it's all done with good responsibility as well. But a lot of that can be handled in the contracting. And some states do not allow them to reduce rates. But I would be remiss if I didn't say that's how in some states the rates are too high, and they go through competition and find other people that can do it at a lower price. And they're not like DHS. They're not focused on that. They're out in the community. They've got bids from competitors, and they say, I can do it at a lower price. Managed care companies say, okay, as long as you meet this quality, and that they've reduced rates. So some states want to give them that flexibility.
No, I would agree with you. I mean, competition can be healthy, but at the same point, one of the biggest complaints with providers as far as Medicaid is concerned is the fact that Medicaid pays for so little, for everything, and even has been testified that they lose money when they actually take Medicaid patients, which again puts a greater burden on our providers to provide quality service, and they're not getting paid.
Yeah, but I agree, but I think you can handle that in the contract. And I would say one thing, if we go back to this slide here, and 37, if you look at that $215 million, now, if you feel that, you know what, the behavioral health area really needs to be managed, and that's an area that we feel strongly we should at least try the capitated managed care. You're going to get some additional funds, and we've said this from day one. The governor stood up here and said, we need to work on our DD wait list. I'm telling you right now, from our our feeling here. Unless you make actual cuts somewhere in the budget, you're probably not going to make a meaningful dent in the DD wait list. Now, you could try to restructure here and there, but we're talking about coming down on the growth. Nothing here is about really cuts. But your behavioral health community, those rates have to change. There needs to be better utilization. So some of those providers are going to be impacted. But here, you're going to have more flexibility to use dollars for the wait list in at least one of the areas, because no matter what, if you go to behavioral health, if you just start in that area, you're going to, $20 million, $25 million in general fund matched at 30%, but actually it's a little discount because it's your 30%, you have the discount. So it's about 20 million if you look at behavioral health. And if you take that and get general funds, federal funds, you could do a lot to target that towards the wait list. So these are ideas. I'm just trying to give you ideas. There's been a lot of discussion about these two models. At some point, I want to make sure you have the information that you need to at least factor that.
Right, but I think you mentioned with managed care, you're stuck in potentially a 3 to 5 year contract that a managed care company would want, correct? Like a managed care would want a 3-year or 5-year contract, correct? They wouldn't do just a 1-year contract and allow us to see what kind of other options we might have with the next administration.
I'm not sure about what they would want.
That's a great question. My experience is that managed care companies would not want to enter into a 1-year contract. However, I'm not aware of any state that's ever put out a bid for a 1-year contract, so I don't know how the market would respond. I do know this, that inside of any state managed care contract, whether it's for 3 years or 5 years or 5 years plus 3 add-on years on a year-by-year basis, there's always a legal out for the state. And critically, it's the availability of appropriations. So there's no guarantee that the state will always have the money. And states have used other methods in terms of what will allow them to essentially stop a managed care contract if it's in a 3 to 5 year phase.
Well, and again, I think that's a point that needs to be made, that if we go the managed care route and we do have a 3 or 5 year contract, and the next administration all of a sudden opens up and says, Arkansas, we're going to allow you to do all this, are we going to be locked into that contract? Because, yeah, you're right if we don't have the appropriation, but can we just say, well, thank you, managed care contract, we thank you for this, but the administration is going to allow us to go into a different direction, and thereby potentially miss an opportunity to really do the healthcare reforms that we really want to do.
I think that's a great thought, Representative Meeks, and I think that can be one of your factors you might want to consider should you decide to go to bid, how you want to frame the innovative aspects of your bid.
Okay. Thank you, Mr. Chair.
Yeah, and I just want to make sure I'm understanding again the numbers on this, because when we talk about slowing a 5% growth rate by 10%, we're still having a growth rate of 4% or so, which is, as you have acknowledged, faster than the rate of growth of our GDP, which means that one of the reasons that I was so adamant that we look at Medicaid is it's growing twice as fast as every area of our state budget right now, depending on what match rates you get. So I think what members here need to understand is, even if we do the $1.5 billion slow in growth, this is still going to consume more of our budget, percentage-wise increase, than anything else. It's going to take more from either education or from roads or from other state programs, because it is growing at a rate that is faster than everything else. So we just have to, unfortunately, there's not an answer that's going to slow the rate of growth and not make people mad. We just have to get prepared for that. Hopefully we can do it without, by fixing it with inefficiencies and waste, rather than, putting it to providers or people who need the services. That's my speech for no charge. Representative Boyd, you recognize.
Mr. Chair, thank you. I just have one more clarifying question. I mean, and I mean this in all seriousness, but we keep hearing about, well, we don't have to worry about it if we, go into managed care, if we do the RFP right, if we have the right contracting in place, if we say you can't do this. But I guess I really have this concern that at some point in time, if we write those contracts and those RFPs so well, we're not going to have a worthwhile company that's going to want to bid on the contract. I mean, does that make sense? You see where I'm coming from?
Yeah, I do. I think it's an issue. I want you to have, if you go down that road, the best contract possible. I keep alluding to the state of Texas because they probably have the best gain share back to the state provision in any state in the country. They figured that out in the methodology. And all the managed care companies said, well, we're not going to bid, but they did, and they're doing very well. You know, I'd like you to be strong. I'd like you to go to CMS and be able to waive actuarial soundness. The managed care companies won't like that. I mean, you know, each year you have to rebase the rate to have actuarial soundness. Well, I think that ought to be waived. So, yeah, I think there's a lot of things you could look at. Maybe the next administration would help you. But, yeah, I think there's an issue that you may not get the best contract. I don't know how to answer that other than...
John, isn't it also true that we will have the same contract struggles or other management struggles if we choose another course?
Yes.
And isn't it also true that there's no guarantees that if we continue on our same course, that we won't head into disaster? There's no guarantee that if we keep doing what we're doing, the growth rate might not grow to 25%. Can you rule out, if we don't do anything different, you're using a 5% projection, can you guarantee me the actuals will not be 45% growth?
No.
You can't guarantee that. So these numbers about the train wreck that's coming, that we're projecting at 5%, could actually be 45% year growth, and we could be $10, $20 billion underwater, theoretically. I mean, and I realize that's a little bit of a silly example, but the reason I'm using it is nobody is able to predict with certainty what the futures look like. The past hasn't been perfect either. I mean, and that's not anyone's fault per se, but the past hasn't been perfect. So all we can do is take the best numbers we have, make the best decisions we can, and then continue to monitor it moving forward and make sure that we're doing the best we can, as far as I can figure.
I mean, well said, and I would say to you that, you know, whatever course you go down is going to have significant changes. The Diamond Care at Risk is a lot of contracting, a lot of oversight, too. You're going to be down that road anyways. You'll not succeed in Diamond Care Risk if you don't do good contracting. You will not succeed in capitated managed care if you don't do good contracting. So, and then, you know, one of the things that I want to make sure that you understand, again, I think this is clear now. At least what I'm trying to make, or our team's trying to make clear to you is that, you know, again, Representative Gray, you're bringing up the behavioral health issues. Those behavioral health questions that you asked prompted something that's going to happen, and there's going to be rule changes, and there's going to be rate changes, and there's going to be some changes. That is going to result in real savings, with or without fee-for-service, managed care, capitated, or fee-for-service. What I am saying to you, though, is I don't think you have enough, unless you really want to start making quick changes and cuts, actual cuts in your budget, to make meaningful changes that would, meaningful spending in the DD wait list. That's, I don't know any way, unless you give us the next question is try to work with DHS to find the cuts. I mean, we can do that. These aren't cuts. But the behavioral health changes will definitely amount to revenue savings, and so will some of the provider plans. And I know the nursing home industry is ready to go, and they all want to help. But you're going to be here 2 years, 3 years down the road figuring out how do you help some of these folks on the DD wait list. And I'm not saying you're going to help them out completely, but that's not in this plan.
Okay, we've got 5 on the list here. Senator Ervin, you recognized.
It goes to the methodology of rates and what you're paying, and this is a broad question, but I know that it's kind of all over the map. You know, you've really got some issues, and has there been any acknowledgement of trying to review that, or are there any other states that use kind of an independent group that looks at rates and says, you know, it's really low here and it needs to be raised here, or it's really high here and it could be balanced? Is there any, you know, because I see that there's really an unbalance in a lot of different areas, and I know that instead of us having, you know, political battle of rate increases, there are some that get cost of living and some that don't. You know, you have specialists that make more, primary care makes less. I mean, you have just all these issues across the board. Is there any mechanism that other states maybe are employing to like have an independent look at that and make some sort of a recommendation to levelize or balance
Yes.
that?
Yes.
Okay.
In fact, you did that, and you hired PCG in 2011 or 12 to do this in behavioral health, and they came out with a full list of changes, and DHS said, okay, and they came forward with all the changes and rates, and it got defeated. Didn't even make it past first base. So,
On behavioral health.
yeah, so, but
Okay.
yes, that can
But
happen.
I mean, I'm telling you, across the board, long-term care, primary care,
Yes.
specialists, orthopedists,
Absolutely.
neurosurgeon, cardio, I mean, all of it.
Yes, and pharmacy.
And yeah. I mean,
Yes.
I'm just saying across the
You
board.
can do that. I guess the question should be, and that's a really good thing, but I think when you look at that, talk to, OMIG is going to be testifying later, they're going to be talking about that. They've already looked at it at some of the areas, what you want. They have a vendor that they've hired that actually has compared other states in your region. And try to maybe do it so that you know what your region rates are like.
Okay, all right, thank you.
But I can tell you, personal care, we know from other states, your personal care, your physicians took a rate cut, by the way, after the Medicare issues and the Affordable Care Act. You've got, and the DD wait list. You got 3 areas that are going to need some, I think you need to put some money into rate increases for personal care,
Okay.
for home and community base, if you move in this direction.
Well, and I'm also referring to like Medicaid. I mean, it's $13 to see a Medicaid patient.
Yeah,
I mean, just, so I
that's, yeah.
I'm not sure how many other people work for $13 an hour. Thank you.
So,
We got a couple more here. Senator Elliott, you're recognized.
Thank you, Mr. Chair. I've been trying my best to listen, and your last comments really, really woke me up. So you can thank yourself for that, for this
Uh-oh.
question. I am curious, since I've been trying to think back historically and figure out where we are today, and if we're going to keep this balloon just growing. So I'm wondering, since the whole of Affordable Care Act was kind of based on the Massachusetts model, that I think has been deemed successful, you can correct me if I'm wrong. To what extent is what we're doing in Arkansas even still kind of like that? Are there some really big exits that we've taken that might have us in a position of constant growth that might not be true in Massachusetts? Just
well, again,
Is
this is a good question. It goes to the heart of this issue. You've got, Massachusetts has full capitated behavioral health, capitated managed care model in behavioral health. They have a vendor there that has looked at that whole area, and they've done a pretty good job there. They have managed care in other areas of their state. They're not a complete fee-for-service state like yours. And what we told you from the very beginning was that fee-for-service system you have has to change, and I think everybody's agreed to that. So that's where a lot of this is it's not being controlled on a management side. So what Diamond Care Risk does is puts more management controls and really starts to look at utilization. What the capitated model, the one in Massachusetts they use, is more, if it goes up beyond certain areas, it's 100% on the company to bear that risk. And they work hard, and there's good incentives, and we looked at that model, and it works well. Virginia does a PCMH model like Diamond Care Risk for behavioral health. So, I mean, it's worked well. They've saved some money, too.
Well, thank you for that answer. And I think the other thing, this is just, I think, a matter about us in Arkansas, too. Massachusetts has about a little bit more than double the population that we have in Arkansas. And I think there are some things they have in place, they've had longer to do it, where they have actually addressed the things that would lead up to needing so many people on Medicaid, period. Like they paid more attention to, kids having a great start and not having so many people in prison. So long term, while we're doing this and the balloon's going to grow, I think I wouldn't want that balloon to keep growing to the point of a mushroom. We're going to have a long-range plan that seems as if it has nothing to do with healthcare, but it has everything to do with healthcare. So side by side, I think there are parallel thoughts here, Mr. Chair, is what I'm saying, that we need to be thinking short-term now and long-range for down the line, because I could see us here in 2020 not having addressed the prison population, getting those people to work, not having addressed all kind of social issues that keeps this thing growing, and we'll constantly be feeding the beast. So for what it's worth, thank you for your response, and Mr. Chair, thank you for waking me up totally and having my thoughts.
That's what I do. Representative Gray, you're recognized.
Thank you.
Thank you, Mr. Chair. I guess my question, as we heard the governor's speech this morning, and
Yes.
we're looking at Arkansas Works and moving forward, I look at the gravity of the decisions that we're getting ready to make, and no matter which way we go, we're ultimately responsible for the budget and for making sure that that we balance it and that the state's taken care of moving forward. So with that, the governor had asked that the alternative plan, Diamond Care, be verified essentially for the savings. Has the managed care proposal, have you verified all of what or do we just take their word, or how do we verify? I mean, because this is a decision with a lot of gravity. In my opinion, it's a huge, we have to make sure that we do this right. I don't want to come back a year from now, we're halfway in a budget, halfway in a year, and we're looking at, we're $600,000 short, we're $5 million short.
And again, we can't say that's going to happen for sure, because we have, it's all about, there's a lot of contingencies, and that assumption chart that I gave you is some of the real important things that you need to consider. But have we verified? That was the question.
Yeah.
Diamond Care at Risk model, I really feel we have vetted and verified. I also feel the same way on the managed care, capitated, because we did look at a range of states, and we tried to identify, okay, what were the percentage savings for each of these areas in those states that we looked at? And then we found the state that compared the PCMH model with a managed capitated model during the same time and did an evaluation and reviewed it. And that was that state we talked about, Louisiana. So that wasn't the only state we used. So then we looked at, we looked at some of the Massachusetts numbers. We looked at the numbers in Texas. We looked Pennsylvania. The other thing is Pennsylvania is important here, because we used, everything, Representative Gray, the states we looked at, we did mention in the report as well. So Pennsylvania had what's called Access Plus. Pennsylvania, in a very large area, had Access Plus. That was your Diamond Care at-risk plan. They took it and they moved to capitated full risk managed care. And Mercer basically did a study of which one is better, and provided that to the state. The Lillen Group did their own study, and I'm going to share that with you. I'll make sure I send it to you, because it's important to look at that study. Because that study actually, and we did put it in, we alluded to it, but I'm going to send you the actual study. But that study showed the difference between the savings for managed care capitated versus fee-for-service at risk in that Pennsylvania model. And they compared that state, and they compared it. Now, did they get it wrong? I don't know. I'm just telling you what we see. Out of all of this, I feel comfortable if you do it right, you could be close to where those savings are. And again, I think that the premium tax issue is an important issue. So that it's not all savings. You're going to get some additional revenue on the tax structure. But, I'm going to share that full Lewin report with all of you. You can look at the same things we're looking at. We're asked to give you advice, and advice from what we've seen in states. But have we gone and actually, found a model that is not working and figure out why and talk to the folks on the ground in a state? No, we haven't.
Okay, well, and just to follow up, Mr. Chair, we got an email from a group, I don't remember the name, it's a name very similar to one that UAMS has that's not affiliated, that they're for managed care companies, and it said, got it yesterday, I believe, $2.1 billion that the managed care companies in total had saved essentially the United States in 2011. So either the data since, I'm going to be rude, either the data since 2011's not worthy of being in the email, or I'm not sure what it was, but 2.1 billion is what they said. And I'm going to say 35 states because we're at 42 states and territories, so I'm going to say 35. That's only 60 million a year by each state, and our population numbers, our density is actually so much smaller than a lot of the other states they have. So I even question their own numbers. Do you see what I'm saying?
Yes.
This is a huge deal for us.
Yes, and I would tell you to look at all of them. You've got the Menges report that we gave you in October. I would read that report closely. That report is an independent auditor, basically, that looked at all of the states on managed care for 2014 and 15 and identified savings in all the states. You could see what the trend is. I would read the Menges report. I also am going to send you the Lewin report, and the Lewin report's important for you because it compares Diamond Care risk to capitated managed care in a state running in the same time. So that's important. Louisiana did the same thing, and we used that. But again, you still are going to have the risks, the contracting risks, the abuse utilization, some of the road issues. There are going to be issues. So what you're seeing in terms of savings, compare that to what we'll send you.
Okay.
Done?
Yeah, but can I say one more thing?
Absolutely.
Okay, he loves me. I just want to follow up real quick on Senator Ervin's comment when she was talking about the $13 an hour. I think she should have followed up with on that is like the actual cost per hour to operate a clinic is depending on what you pay your physicians, and some that are in their own practice don't actually pay themselves. You're looking anywhere between $100 and $130 an hour. So if you see a patient for $13 in that 1 hour, you've lost, how much? $90-something, $100 an hour you're losing.
Yeah.
So, people think, well, I work for $13 an hour. Well, but you don't spend $100 to make 13. So it is a big issue in Arkansas. We'd have to see 10 patients an hour to actually make up our expenses.
I think that Representative Gray's point is a good point. There are areas in your program compared to other states that you are not paying meaningful wages in Medicaid. And that concerns us. It's an access issue. But there are other areas where you're paying way too much. So that's, whatever road you go down, that's one thing we hope is going to be fixed. But again, if you want to make meaningful additions to the help to the wait list, you're going to need to go down a capitated managed care model, in our opinion. If you don't, you can still make some additional reductions, but they're going to have to be not just off of the growth factor, and we could help you along that way. And that's about all we have. The two things, Senator Cooper had issues on corrections and mental health treatment. We answered that. There's an Urban Institute report that's attached that all of you will have. It's really important read. And then Senator Ingram, I don't have the DD comparison states with me, the charts, but I just got them in from our data analyst in the Boston office. And the comparison is basically you're at the middle in the spending around states. You're somewhere in the middle on DD. And I'll make sure you get all those charts after this meeting.
Okay, Representative Farrar, you're recognized.
Thank you. Physical therapy is one of those that don't get paid enough by Medicaid, by the way. I just want to tell you
What's
that. I got a real simple question. Do managed care companies go under the boundaries of the medical loss ratio?
Yes. They actually have a CMS requirement.
Yeah.
So they have the 80-20?
80-20.
Just like 80, okay, so there is a controlled mechanism over.
CMS actually has a rule in 2015 that they went forward on. The Medicaid directors had a concern about it, and they issued a response, and I'll have to figure out exactly what happened and get that to you.
Okay.
The rule was 85-15 for Medicaid programs. National Association of Medicaid Directors says it really ought to be set by states.
Okay.
It's slide 42. I put that in there for you.
Okay, so it is.
It's in your PowerPoint, slide 42.
We didn't go that far. Okay, well, great.
I knew the question was coming.
Okay, all right, well, thank you. And also, you said a while ago that you wish that CMS would waive the actuarially sound?
I've always felt that way as a former
Why?
commissioner.
Is there a reason why?
I mean, I think that there are issues on, growth. I think we've got to figure out a way so that it's not constantly growing at certain rates, and that goes to the heart of this issue here. And when you have growth factors built in, actuaries look at it, but there are times where I believe strongly in competition, and maybe someone would come down at a lot lower amount. And I believe myself personally in a real competitive environment. And
There's also a good reason for a state to think about this. CMS wants states to look at value-based purchasing, and one of those value-based purchasing is the bundled service. Now, Medicare allows that, but you can do that in Medicare, but you can't do it in Medicaid. Suppose a state wanted to say, we want to manage care, we're going to put out a managed care bid for $3 billion, and that's it. And that saves you $500 million from your prior year actual expenditures in real cash, no actuarial capitation. Just say, we'll give you $3 billion, this is what you got to do. You can't do that.
Senator Urban, you're recognized.
Yeah, one thing to note on that conversation, I think Ms. Gillespie, who the governor's, she co-authored a position paper on that Medicaid rule change through
Yeah.
CMS, and because of the growth in Medicaid and the numbers and the expansion of Medicaid, more managed care coming in, that's what preempted that rule change from my reading of her position paper on that proposed rule. So I just wanted to
I think you got a good opportunity to work with the director on those issues.
bring that to light. But you had asked for any other recommendations before the March 7th meeting, and that's why I brought up the rate levelization. And that's what I really, Mr. Chair, would really like to see some sort of a recommendation on those different rates and where they're at, and just so we have a clear knowledge of where those areas are and what recommendations that can be made for the mechanism to rebalance. So I would just formally request that. Thank you.
Okay. Representative Charlotte Douglas.
Yes, thank you, Mr. Chair, and I have two questions, if you don't mind. Just curious, the reports that you were going to send to the committee for us to look, you mentioned the Lewin Group.
Yes.
Who authored that study?
The Lewin Group.
Okay, and what kind of group are they?
They're a group that, interestingly, they're actually owned by a managed care company. But prior to being owned by a managed care company, they wrote that report, I believe. So they're owned by United, I think. I'm not, is it United?
But they're independent.
So you still feel like that's a
I
credible
think the report
report?
that I'm going to send you was before they actually had been acquired, but I'll double check.
Okay.
And the other issue is the Mengis report, they're independent, and that's in the October, and I'll resend that to the chairman.
Okay,
That's in the October final report that we gave. I think it was October, it might have been November update.
Yeah, I think that would
Mengis
be
is one that just came
helpful
out.
in light of, transparency for
Yeah.
us to be able to.
And the Mengis report came out in October of 2015, so I think that's a good report.
My question is, are there states where Medicaid populations are not growing? And what can we learn from those states?
Populations or cost, or both?
Well, populations mainly is what.
I'd have to look at that. I mean, the last few years, Medicaid costs, we did provide that to the task force, have been pretty much kept across the board, states on average, in the 2 to 3% area, which has been really good. CMS is projecting over the next 5 years somewhere around 6% growth. We decided to stick to 5% growth.
Nationwide?
Nationwide, 6%. But when we did 5%, we even thought, should we go to 6% here? Because the aging population that year, like 2000, I don't know if it's 19 or 20, your aging population goes up a little more than most of the national, other states. But 5% was what everyone thought. But to say population is a different question. So I'd have
Numbers.
to, I'd have to look at that.
Like percentage of their population
question.
for their state. And, that might give us somewhere to look for some, some ideas about reform.
It's a good question.
Thank you.
We can get that information.
Thank you.
Senator Stubblefield, you recognize.
Thank you, Mr. Chair. John, just a quick question. I know you've covered a lot of information, and I may have missed this, but was the topic of telemedicine and the overall effects that telemedicine might have on this whole process, was it ever discussed?
Yes, it's in our report.
It's in the
one of
report?
Diamond Care at Risk embraces telemedicine. We agreed that we thought to confirm the savings, we think you need to work with the physicians and really enhance your statutory framework today and really make it happen with some of these populations, and you could save money. So yes,
Okay, thank you, that's all I have.
it was a great idea from the Diamond Care.
Representative Gray, you recognize.
Thank you, Mr. Chair. Two things, and then I'm done. The first is, like, I'm looking at the Lewin Group, and they were actually, that 2011 were sponsored by healthcare managed care organizations, AmeriHealth, Gateway, Health Partners, Keystone, United Healthcare, so.
Which,
the Lewin Group. that
Yeah, but which
from
report? Is that the-
2011.
is that the Pennsylvania report? Because it
Yeah.
may be.
It's an evaluation of Medicaid savings from Pennsylvania's
Yes,
health
yes.
choices. So
Then
it was
that's it.
actually sponsored by,
Yeah,
so I
correct.
kind of don't feel that, I think that's a little biased more than likely. But my second,
But look at the report, though, because
Okay.
it did use the state numbers, and
Okay.
so we felt pretty good about it. But just, I understand your point.
Yeah.
Definitely, but that's why I point also to the men's report, which I thought was a very good independent report
Right.
for you all.
Okay. And the one thing, I'm sorry I missed this other part of your presentation, but I know we had discussed at one point in time as we were working through the behavioral health and DD savings plans, as I've learned about CHMS and DDTCS, they provide a lot, in my mind, and I'm sure I don't know all I need to know, but they provide a lot of the same services. Is there any way that you could combine the two into one robust program?
Well, in a global waiver, you could do a lot of combination of services with a CMS waiver. But some of the services, though, and Richard, correct me if I'm wrong, some of the services would require different types of assessments. The only issue is going to be your assessment tool is going to have to be different.
There are different provider credentials for CHMS services and DDTS. There are fairly significant differences, just as there are between RSPMI. And also, I think there are fairly significant differences in population. I think it's important to note that CHMS generally treats 0 to 5 years of age, and I question, for a lot of different reasons, but certainly from developmental medicine, why that's listed as a developmental disabilities program for that age group. And I think they do as well, and there's plenty of medical evidence behind that you can't really make a diagnosis for many of those children. And also, a good proportion of those children also go on to regular school at the regular age, which is significant and is more related to the IDEA, early intervention, involving learning disabilities as opposed to developmental disabilities, whereas DDTS obviously is oriented more towards developmental disabilities. So, but it's definitely something to take a look at, and we do recommend that you look at the construction of the three benefits.
Okay, thank you.
Representative Hammer, you recognize.
Thank you, Mr. Chair. Telemedicine, would you define what you mean by telemedicine? Are you talking about working in-state with UAMS, or are you talking about allowing telemedicine as being used in other states when you talked about that a minute ago?
We only apply to current practice. We felt that the rules, there was some advisory group was moving on some of the rules, and we wanted that to be done quicker. And we feel that the Diamond Care, but with risk, allowing for telemedicine with your Arkansas providers working and having under their direction, that would work.
And
That's what
other
we're
area-
referring to.
What other areas, you mentioned about access, what other areas did you explore, did you point out? I know there's a couple, but what other areas did you touch on that would allow access within what you were talking about a minute ago?
To allow access?
That would allow access, do you have, besides the telemedicine, were there any other points of access that you saw that would help lower the cost if the model
Yes.
was changed, and
I mean,
what are
I
they?
think what you're referring to, too, you had mentioned a while ago on the APRN, the nurses area, and we had recommended in the report that when you deal with a high-cost population, that you involve the APRNs working within the PCMH framework under, again, the current environment, working with the doctor and under control of the physician, but not necessarily having to be the physician in the PCMH system, because now you're dealing with a lot higher costs, especially in the area where you have age, blind, and disabled that now is going to have high chronic disease and others that nurses could be a big part of. That would be, we feel that would be a really good system for you all. And again, it's consistent with this whole enhanced care coordination, but again, within the current structure of your state law.
That current structure, is that aligned with other states as far as how they've gone about lowering the cost, whether it be in the telemedicine or the APN, or how are we aligned with what you see in other states?
We've seen in other states the nursing component that I just mentioned save in examples, but to say, is your statute aligned with others, I haven't looked at that.
All right, thank you.
Okay, that's all we have on the list. We're getting ready to leave this item, and I want to thank the Stephen Group for giving us the information on this, and for members' information. Obviously, we've had a couple different paths forward presented. Obviously, fully capitated managed care and risk-based managed fee-for-service. We will be asking the Stephen Group to include those paths as the possible recommendations. And again, you all will have in your hands by March 1st what that will look like. And if you have problems with that, we'll have a week to sort it out. Because again, we want a fair representation of every idea presented, and then we'll determine a path forward. So, but I hope what we got here today gives us the tools to be able to compare and assess and make a good decision. At least that was the intention. So, having said that, we're going to move on to item F. So I think Elizabeth Smith and Director Seelig are going to come down and talk about item F, behavioral health TSG recommendation, what you have discovered.
Good afternoon. Thank you.
Welcome. If you just state your all's names for the record, and you're recognized.
Thank you. I'm Elizabeth Smith, Medicaid Inspector General. You're at it. Go ahead and introduce yourself.
Good afternoon. My name is Bart Dickinson. I'm Chief Counsel of the Medicaid Inspector General's Office.
John Seelig, DHS Director.
Dawn Staley, Medicaid Director.
Charlie Green, the Director of Behavioral Health Services.
So we were asked to provide a plan from the Office of Medicaid Inspector General regarding Medicaid program savings. We specifically looked at behavioral health and RSPMI, and then we also looked at one specific billing code I mentioned to you last time I was here about a month ago. As you know, the Office of Medicaid Inspector General is charged.
Just a second, we're going to make sure we're handing out your slides right now.
Oh, yes, thank you.
Give them just a minute and then press on.
Certainly. Okay, thank you. So as you know, we're charged by both federal and state requirements to identify fraud, waste, and abuse in the Medicaid program. We have a new payment integrity improvement initiative through the Office of Medicaid Inspector General, where we're working with DHS as well. And then we also have some projects and initiatives to tell you about. As you know, the federal program integrity requirements are that we look for areas where we need to recoup or recover payments that were inappropriately made for whatever reason, or overpayment on claims. We look for fraud, and we refer those cases to the Attorney General's Office, the Medicaid Fraud Control Unit. And our referrals are up this year since before. We also work with providers on the False Claims Act compliance. The False Claims Act compliance requirements from the federal government is that any Medicaid provider who receives more than $5 million has certain compliance requirements. They need a compliance department to ensure compliance with Medicaid rules. Also, they're supposed to be telling their employees about whistleblower protection and those types of things. So we work to send letters to all those types of providers that spend $5 million or more, and we reach out to them. They are supposed to, we work back and forth to ensure that they are compliant with this requirement. We also work on provider education, both through our audits as well as with the contractors through DHS. And then we have provider action plans. When we go audit a provider, we oftentimes will find areas where they need to correct, and that will find savings in the future. So the payment integrity improvement for this year, we are seeing increased efforts of self-reporting. We encourage providers to let us know if they see a problem, if they have overbilled Medicaid, or if they see a problem with their system that has allowed them to receive overpayments. We ask them to self-report. We try to work with the providers so that we will be fair to them, because it's easy for us to, when they find they've received money they shouldn't have, for them to simply return it. It's easy for us. We don't want to beat them up and then go dig in and look under every corner. You know, we like to work with them and just check what they've done and make sure that's good. We use cost avoidance data analysis. I told you about this when I was here before. We have data analytic tools, and we have a couple of people on staff that utilize those tools to determine outliers in Medicaid billing, where there may be a provider who spends more in one area than the other providers, and then those are a way that we can identify who to audit. We have a review that we have begun under the Payment Integrity Initiative. We are also looking at the Medicaid contracts. We're required to do that by statute as well. We are looking at the contracts between DHS and other various Medicaid money that's spent, and we're making recommendations on that. We are also looking at various DMS programs. We're recommending reforms under the MMIS payments. We're looking to make sure that those payments are made appropriately. And as you know, we have the MFAD brewing, potentially a enterprise data fraud analytics tool that we'll be issuing an RFP for. We also have increased utilization of our federal contractors, and I've explained that, and we'll go into more detail about our specific contractor, Advanced Med, through CMS. Our initiatives and recommendations, we have worked on review of pharmacy, and we've made recommendations for edits. There was recently an edit and some changes made by DMS. I think this came in conjunction with some changes to some pharmacy regulations. And so what we will see with these initiatives is that there will be savings going forward. We've identified Medicare, Medicaid crossovers. When a Medicare claim is made and there is a Medicaid patient, they're called dual eligible recipients. There's dual eligible recipients, and if a Medicare claim is denied, the Medicaid claim is also supposed to be denied. But Medicaid pays quicker than Medicare, and our computer system was not automatically catching those payments and reversing those payments or collecting those payments. And so we have been working with DMS over the past few months to identify and recover a good deal of money in that area.
Okay,
And
we've got a question, if you don't mind. Representative Boyd, you recognize for a question.
Thank you, Mr. Chair. Just to clarify, so you just talked about low-income subsidy patients and they're dual eligibles, and so they have both a, Medicare card or a Medicare Advantage card, and then they have a Medicaid card. So if there's a drug that's not covered, like, say, an antihistamine, that Medicare Part D doesn't cover, then you're saying you can't bill Medicaid for that?
Can you answer that?
Yeah, I can. What we're looking at actually is in circumstances where it's a dual, where we're using Advanced Med as well, our zone program integrity contractor, and what they've identified is when there have been reversals of Medicare paid claims, but yet in the current Arkansas Medicaid program, a provider is required to submit and notify HP when there's been a Medicare reversal, and then submit that reversal based on that Medicare payment. Well, what we found in the past, the system currently sets up is the burden is on the providers themselves to do this. And so in circumstances where a provider is paid by both Medicare and Medicaid, and then Medicare is reversed, the provider currently is required to submit payment back for the Medicaid portion. That hasn't been happening. Okay. So this is a little different than what you're suggesting.
Okay, I wanted to understand.
Good.
You bet.
Good. And in fact, the pharmacy is separate. This necessarily, Medicaid crossover reversals doesn't necessarily have to do with pharmacy. Right now, what we're looking at is,
Murdoch, you recognized.
Okay, trying to follow what you were just saying. In that situation where there's a reversal made and the pharmacists have given the product to the recipient, how do they get paid if they have to pay both of those back, Medicaid and Medicare reimbursement?
We're mixing two things here.
Oh, okay.
Sorry, but we're not talking about pharmacy when we're talking about Medicaid crossover claims. It's a different, Medicare, Medicaid crossovers, we're not talking about pharmacy. We're talking about Medicare Part B, we're talking about DMEs, we're talking about hospital claims, but not pharmacy claims.
Oh, okay, I'm sorry.
so, and I should probably slow down. I know you guys have been here for a long time this afternoon, and I was trying to kind of run through and get to the good part, because I want to wake you up. I mean, all of it's good. I'm warming you up, but, so these are each different. So then, go ahead.
Real quick, so even for services rendered through a physician, I guess, and is reversed, so that's reversed because it's deemed a non-reimbursable service,
Exactly.
I guess. Okay.
That's correct. That's correct. And these crossover reversals amount to not a large amount per physician or per provider. Is that a good way to say it? They don't amount to a lot of money per provider per claim. But when you add up all of them across the board, we're looking at $300,000, $353,000. Okay, we're also looking at dental as well as optometry. They don't necessarily go with the pharmacy or the Medicaid. These are the separate initiatives that we've been working on this fiscal year. And we have started doing something called cost avoidance letters and analysis, where we are sending letters to providers where we may find a certain issue occurring with a provider, a group of providers. They may be, for example, this Medicaid crossover reversal. That could be something we could utilize as a cost avoidance measure, that we would, rather than going in and auditing every single provider to see if they had returned their crossover payment, we could send a letter to them and say, please look at this problem. We expect to see that you will reverse or you will pay back. So with cost avoidance letters, we are finding that if we find outliers by the providers, if we send them a awareness letter and say, you're billing outside of the norm, please check your practices, then they will in turn respond. So the exciting part of today is we specifically looked at a billing code 90853, group psychotherapy, through RSPMI. You've been hearing a lot about that from the Stephen Group. They were also looking at behavioral health. We started looking at behavioral health issues. We had a couple of fraud referrals that were pretty significant regarding RSPMI billing. We were concerned about that, and we're trying to figure out why. Why is that? Why is there such a large amount of, these two large amounts of fraud that we found in that area? There have been 2 other fraud referrals in the past in the same area for RSPMI, and so we were just looking at that. We also were working with our Advanced Med contractor, and we were looking at dual eligible recipients. And for some reason in this particular code, the Medicare claims were not being billed, but the Medicaid claims were being billed. And so we wanted to understand that. So we looked at the actual billing code, and it turned out that Arkansas is an outlier among the other states. I told y'all that when I was here before. We spend more than the other states in our zone, pretty much do. So we were wanting to make a long-term reform plan. I'm going to show you our PowerPoint that we have from Advanced Med. This is our zone program integrity contractor, and they are given to us by CMS. We have in our zone Alabama, Georgia, West Virginia, Tennessee, Mississippi, Louisiana. We also have, okay, that covers them. Arkansas spends more than the other states, except for Georgia, and I'll explain that. I'll explain that to you in a minute, on group psychotherapy. We looked at group psychotherapy billing. We have a comparative analysis of our Arkansas policies, looking at units billed, amount of time spent with the patient, and that type of thing. We also have looked at the analysis of Arkansas expenditures. We have recommendations, and I'll tell you our recommended cost savings here in a minute. So y'all might have seen y'all might have seen these numbers last night. There was a story that ran. I didn't know that was going to happen, but these numbers were shown. Arkansas spent between 2013 and 2015 $147,961,241 for group psychotherapy code 90856. Alabama spent $8 million. Georgia spent $3.3 million. Mississippi, $7.7, Louisiana, $500,000, Tennessee, $1.7 million, West Virginia, $445,000. Now, Georgia and West Virginia, we got some information from Advanced Med over the weekend. I actually received it Monday, and what we asked them to do was look and see if there were other services that were being utilized that's not the 90853 billing code. Because when you look at this, you think, wow, why is Arkansas so different? And we actually had some discussions, and we had some people say, well, probably other states have other things, and they spend Medicaid money in other ways to cover group psychotherapy. So we asked Advanced Med to look at that for us in our zone. And I don't have a slide for you, but I can tell you the number for Georgia is actually 33 million instead of 3 million. They use another code called H004. So Georgia is actually 33 million, and then West Virginia, I think, was, hang on, I've got that here, 10 million. And they utilize a host of other codes for group psychotherapy. But I'll show you in a little bit about the numbers for Georgia versus Arkansas. We actually have fewer recipients than Georgia does, and so we're still, even though Georgia was 33 million and we were 147.
So we have
Is that right?
fewer people that were coded and got this service, and we spent 4 times as much.
Right.
Okay.
So we think there's some opportunity here. So here is group psychotherapy allowed amounts by state. We've got Alabama, Arkansas, Georgia, Louisiana, and Mississippi. And these are the per day rates here. Alabama is $23 per day. Arkansas is $82.80 per day. Georgia allows $15.68 for under 21, $28.92 for over 21. Louisiana's $22 and Mississippi's $44.
Is that per year a cap that they have set by policy or something?
Right, so here's the next slide. So this shows the limits and the policy comparison. So what you see is and this is just for this specific procedure code, 90853. In Alabama, their unit is 90 minutes, where Arkansas is 15 minutes. But we have a daily unit limit of 6, and Alabama has a daily limit unit of 1. So basically, Arkansas and Alabama allow the same time of service per day, but theirs costs $23 and ours is $80 to $80.
About 4 times as much.
Right. So they have Alabama has a yearly limit of 12, and Arkansas does not have a limit on how many days you can receive group psychotherapy.
Okay, surprising, that's got a couple questions here. Representative Douglas, you recognize?
Yes, this work that you're doing, let's see, is this a result of the legislation that was put into pass in 2013 that set up this task force or set up your office?
So the agency was created in 2013 by statute.
Right.
Yes.
And so, is this your first report?
No.
Okay.
But I was asked about the behavioral health initiative.
Oh, okay,
So this is my
okay.
first report about behavioral health.
Okay. So there are other reports that we can go to find areas where over the last 2.5 years?
Yes, we file quarterly and annual reports that are required by the legislature that show our numbers. I don't know if we've filed prior to I came in June, and I don't know that we've actually filed reports to this detail about specific recommendations that OMIG has made.
Okay.
But OMIG works with DHS. We're charged to work with DHS on making recommendations for policy changes
Right.
and things like that.
Well, my question on the group therapy is this coming from, can you tell whether this is coming from just general population that's within Medicaid, or is this coming from referrals through, foster children? Is there a specific group that may be abusing this more than others?
Well, and we're trying to identify.
maybe not.
We're trying to identify if there are specific groups that are utilizing it. What we have done, and one of the ways that this kind of all came about, we had a couple of fraud referrals with 2 specific providers that were, you look at all the billing, you pull up a chart of the billing, and their billing was way higher than everybody else, and so we went and conducted an audit.
But you
And-
would be able to tell if it's coming from DCFS or if it's coming from you would be able to target which group it's coming from?
We should be able to, yes.
Okay. And you would be able to tell whether it's a day group or whether it is people that are in, overnight care, that kind of thing, to give
Right,
us some guidance?
We should be able to, and the Stephen Group they presented about the dual claims within the day, 3 different claims in the same day, and so that's something that we just received from them, and that we're looking into that, and we're gonna we're gonna get to the bottom of that for sure.
Okay, members, we got 4 on the
Thank you.
list, and we're late, and got 4 more other items, so try to help us press through here. Are you done?
If I could just ask Dr. Green, is there some progress being made on the issue that we're talking about the billing on Medicaid for school-based mental health?
Yes, ma'am, we hope there is. I mean, we're hoping that what comes out of this task force and the governor's recommendation for us to go forward is to allow us to get to, as you and I have talked, an outcomes-based program that allows for a little more efficient utilization of our funds. And as we've talked about, in the schools, it's probably about as efficient as we're going to get, so.
Okay, the schools are not allowed to bill at the 100% rate. They have a percentage below that, so, if they could bill at the same rate that private providers are able to bill, I think that would be would seem like the fair thing to do. So
Yes,
I hope we're working toward that. Thank you.
Senator Elliott, you recognize?
Thank you, Mr. Chair. Ms. Smith, I wanted to be sure that I understood on that very first chart that you showed where Arkansas's numbers are very high and the other states were not. You did say that that may be because they are dispersing their costs into perhaps different baskets as opposed to all of one. Did I understand that correctly or not?
That was the concern that we had. When we first saw these numbers, we wanted to make sure that we had the right, we were looking at apples to apples, I guess.
Yes, yeah.
And so that was when we went back to Advanced Med, and they pulled for us a sheet, the thing that I just got it yesterday, so I wasn't able
Okay.
to add it to the slide. But it shows the various codes that can be utilized or that are utilized, at least within these states in this zone. And it shows that Georgia uses an additional code, which is H0004, and West Virginia uses like 6 other codes.
So to get a clear picture, we would probably need to add those two codes together. That would give us an apples to apples, is that what we're saying?
Right, which is
Okay.
what we did, and that's what I told you those additional,
Okay,
those
yeah,
numbers were
that you gave me
33
for
million and 10 million.
Georgia and West Virginia, those two.
Right.
Yeah. Okay, and then finally, do we know, since we compared ourselves only to our zone, do we know anything about the efficacy of our zone and what we do compared to other zones?
We are working on getting that information.
All right, thanks, Mr. Chair.
Representative Hammer, you're recognized.
I want to make sure I don't confuse two different issues. We've got a policy issue that allows for the billing, that allows for the different rate structures that were being compared against other states in the zone. And that's all allowable by policy, but whether that's a good practice or not, that's what we're here to debate for efficiencies, to see if we come more in line with the other states. But of the providers that you're talking about, that you found two that have conducted fraudulent activities, how was it that they conducted fraudulent activities operating outside of the policies that allow these kind of differences? If you can talk about that.
It all comes back to documentation. When we do our audits, a field or a desk audit, we're looking at service to billing. Well, they're allowed to bill, and when they bill through the MMIS, they don't provide documentation to support the billing. We have to go out and say, you billed $30,000 in March. Now, where's your documentation to support your billing? And that's where we catch the fraud, is because it's a pay and chase. So they've already been paid, they've already billed that. It's up to us to go out and say, do you have the documentation to support it? And when we go out and do an audit, if we find they don't have the documentation or we find fraud, that's when we have a trouble and an issue. But they're allowed to bill. In this situation, group psychotherapy, you get a prior authorization, you can do unlimited group psychotherapy billings for a recipient because of the policy and the program. So we have to go out and say, do you have documentation to support every one of your group psychotherapy billings for that recipient? And if they don't, we've got an issue. We've got an overpayment issue or a fraud issue. Well, with there being an unlimited amount, these providers kind of went off the chart when it came to billing. We found them through data analytics showing significant billing and significant group psychotherapy billing, and that's what keyed us to them to go out, to find them, refer them, and they've both been arrested and charged, and I think combined, it was over $1 million they've been billing the last couple of years, utilizing and taking advantage of our policies to bill.
Okay, and did you find in researching the zones that any of them did like a per diem rate with the child, or was it all billed out by individual codes? There wasn't like a set daily per diem rate where they would provide package services to that child?
What we asked our ZPIC, our zone program and our zone program and area contract advance made to do is say, show us group psychotherapy billing per state. And there's some more slides. And what we are seeing is the policies per state and how much the restrictions, the limitations, and what they bill for that one specific RSPMI mental health code for group psychotherapy.
All right, and Mr. Chair, I know we're late, but at some point, I think it'd be good if we could have a, how does a child get in the program, who allows that to begin the process, and what's the monitoring along as far as it's just left up to the therapist or, you know, the assessment at whatever point you would allow that. I think that might help shed some light.
Yeah, I'm sure we're going to have some more discussions about this. Senator Stubblefield, you recognize?
Thank you, Mr. Chair. Can you tell me how long this has been going on?
How long has
this been going on? That Arkansas has been paying this huge amount of, and really the crux of this is, the fact of the matter is, it's because there's no limit on the group therapy sessions that are allowed. Is that not correct?
That's
How long
correct.
has this been going on?
Our records, the information that we are providing is from 2013 forward.
2013?
Right.
And the oversight for this comes from where? Who's accountable for making sure that these sessions even take place, or the huge number of sessions that you're being billed for? Who's accountable for that?
We are.
Then why haven't you been doing it? Have you not noticed the discrepancy among these other states?
So
They average
we as the
3.7 million.
state,
We
and
pay
and we
150?
are doing that. We are here now to do that. We have to make changes within our policies, and I have some recommendations for that.
It took 3 years to do this?
Well, again, I think the OMI, the Inspector General is really not daily oversight of the program. They've responded to a fraud complaint and brought this to us.
Nobody
So,
noticed this for 3 years?
every time we have a task force meeting, Senator, we find stuff that nobody's noticed. And that's part of the reason we have a task force. Because as we've said, we are an outlier, not just on this program, but a lot of programs.
We're talking about enough money to fill the hole in the Medicaid.
On one billing code.
Yeah, and again, this is important work that we're doing here, and I appreciate you all bringing this here, is because people talk about cutting providers or cutting services. There's another choice, and that's making people do what we pay them for.
Well, I agree with that, Mr. Chairman, but my problem is why it takes so long for us to see what the problem is and address it. Why it lags
I
on for
think you
years
might
and we
ask-
spend $150 million.
Well,
That's
again,
my problem.
I think you're yelling at the wrong person, is what I'm saying.
I don't mean to be yelling, that's just my.
We can talk to DHS, or we can talk to whoever supervises that program as far as group therapy and behavioral health and disbursement of those funds. But again, the Inspector General is the one who has found it and brought it to us.
Well, I appreciate that, but I need to ask, how many providers are involved in this?
Total RSPMI, I'm not sure.
I don't know, I mean, if
Do
DBHS has something
you take bids on
about,
these providers?
I don't.
Then how do they get the contract?
There's about 60 RSPMI providers in the state. They don't bid on a contract. I mean, they can, it's like a doctor's office. They can accept a Medicaid-eligible child or adult and get a prior authorization from the vendor that Medicaid has a contract with.
Well, how do you go about choosing the ones that get that contract?
There's not a contract.
Well, how do you go about choosing the ones that get to do the work, the therapy?
Well, there was an enrollment period for years, I want to say 15, is that right, John? Close to 15, 20, where if you wanted to be a behavioral health provider, you could present yourself, and if you could meet the qualifications, you could be one for a particular area. And that went on up until 2007, when we put a moratorium in place because this program was growing at 12% in the department. Now, I was in a different place then, but the department realized it was out of hand and started making efforts to get control of this. And one of them is putting a moratorium in place, and we've come over here every year since then to keep it in place while we've struggled to make reforms. Let me just one more to answer your previous question. Right when I came to behavioral health, and it wasn't due to my diligent efforts, but the staff had already proposed to bring this rate down and bring us the service limits into line with other states and reform this, but we just couldn't get any traction to get it through public health and rules and regs.
Was there a certain group of these providers that got a larger percentage of these therapy sessions than the other 60?
Now, that part I don't know, Elizabeth may know. I think almost all the providers use this code.
I would like, Mr. Chairman, I'd like a list of the top 10 providers and what percentage of the work they actually done here in Arkansas.
We can get that, Elizabeth will get that for us.
Thank you, Mr. Chairman.
Thank you.
Yep, so we got one more. Senator Irvin, you recognize.
Thank you. Just wanted to point out that OMIG wasn't created until 2013, so this problem existed long before that. It was just not. And so that would be a question for DHS, and I know Mr. Green was not at that position. We've changed over, but And you kind of alluded to that, but I think it's fair to say that this has been ongoing for years. And, I mean, is that a fair statement to say, Elizabeth?
I would think so.
Okay.
So we have some recommendations. I appreciate that, that Office of Medicaid Inspector General was created in 2013. The program integrity function is required by the federal government through CMS. That was housed at DHS prior to 2013. And so this is a new agency, and I came on in July, end of June, early July, so.
And your role is to also look at the Department of Human Services as well, as you're you're an
correct.
independent person looking at both sides of it, correct?
That's correct.
Okay,
That's
thank
correct.
I'd just say, for years, we have seen issues with this program and have been trying to reform it and have just really struggled to, as Dr. Green said, we eventually put a moratorium on it to at least not have more providers. But we have not been able to get a handle on it. And part of what's helped here is the governor allowed us, with your support, to create this payment integrity unit, because it takes some real work to dig into these claims, and as Senator Stubblefield said, to figure out who's actually doing what and where, because this is one of obviously hundreds of programs in Medicaid. And as the Stevens Group said, you've got to have some capacity to manage this well and to dig in. There was an issue earlier about can somebody dig into these claims? That's what we now have more capacity to do than we did before.
And let me.
I agree, and I appreciate that. I've helped you fight for those moratoriums because I understand the concept, but I think it goes back to that rate equalization too. I mean, this is a good example of looking at those codes and drilling down to understand if what we're paying is in line within the region and where those are, whatever outliers there are or mitigating factors, access to care or whatever, have to be obviously addressed in that. But I mean, this is an example of one code that needs to probably happen with all the codes, I would say. Thank
Right,
you.
and we'll make recommendations on those too.
Yeah, and I appreciate that, and this is going to be a process that takes a while. One thing I want to ask, I think, Ms. Green, you said, was there a rule brought to the legislature to change the policy that would have stopped some of this?
There was a reform package that was put out for public comment in the fall of 2014. When we got to public comment, we tinkered around with it based on the package based on that. When it came time to bring that back to public health, there wasn't consensus to bring it up and discuss it, because I think at the time there was a lot of discussion about we're going to have a new governor in a few months, and he's going to have his own ideas. There were several things that the department was trying to do. I know this was the one I was involved in, and we said, okay, we'll try again once the governor's in place. And then, of course, this group was formed, and we've been working through this group instead.
Okay, and again, this is like some problems we've seen in other areas, as many times we want to, it's our fault up here for not approving stuff because political pressure is brought to bear. That's just the fact. But hopefully.
Mr.
Yeah.
Chair, I think also, though, it was not, you said that the discussion had stopped. It was not, was it brought before and denied or shot down or voted down?
We never got to discuss it in,
You never
we have to
discussed
come
it
to
in
public health
committee.
first, and we just never got to discuss it in
You
public health.
never got to discuss it in public health?
That's correct.
Okay, that needs to be clear. So that
Absolutely.
was a decision made by the administration?
No, ma'am.
I mean, the executive branch?
No, ma'am. Well, I mean, I'll let John answer.
Okay. Well, I'm not sure, because
I think I can help. I mean, often what happens in these situations is we'll work with the stakeholders, meaning providers, advocates, and others, to try to reach consensus on something. And we'll also work with whatever committee, the individual members of the committee, to see if there's enough support to bring it forward. And frankly, is there a chance that we can actually get it through? If it's clear that the committee members, enough of them are not ready to take it up or are not going to support it, we don't bring it in front of the committee feeling like we're going to waste the committee's time. So there are many cases where we do not bring things in front of the committee because it's been made clear to us by one or more members that it just doesn't have a chance to get through. And that was the case in this one. People said, we're not ready for it. There's too much dissension. You don't have enough consensus among the providers. You need to go back and work on this some more. So that's what happened with this one.
for the providers, okay.
Right. So
thank
you're
you.
right. It never came for a vote to Public Health Committee. In
All
fact,
right,
I think,
thank you.
Madam Chair allowed us to come just talk about it in brief, but we didn't try to get a vote on it because it was clear it just wasn't ripe yet.
Okay, thank you.
And if you, all right, Elizabeth, let's come back to you because I think everybody's pretty well got the picture here. But would you talk about your recommendations on what they would save, and would it take a rule change to do that, and I suppose that it would, because what I would hope is if that's the case, we'll see a rule change up here in the next few weeks, and we'll see if it passes.
Okay.
Anyway.
good. Yes, we do have some recommendations. Real quickly, the billing code, you can basically, in Arkansas, you could bill for an hour and a half, $82. It would be $82 per person. You'd have 12 people in your group, so you get basically over $1,000 for one session. Just to answer that question, I think that was asked earlier about how much people get paid per hour if they're a Medicaid provider. Most of the psychotherapy sessions are billed at 6 units. That there is a prior there is a prior authorization required, so you'll see that. We do see a spike in the summertime. This is for children. The red line shows a spike in the summertime. The blue line is for 21 and older. So we have some recommendations about that. All right, so our recommendations are to reduce the payment from $82.80 for a day to $40 per day per recipient, and that kind of falls more in line with the other states. We would also recommend a cap on the number of units from 60 minutes, to 60 minutes from 90 minutes. Right now, we have an hour and a half group therapy session as a cap, and as you saw, most everybody is getting that hour and a half, and we would recommend a 60-minute. Also, we would recommend a cap allowed number of units per recipient at 150 per year. And so that would be, if we, okay, so this was developed by Advanced Med. If we had a 6-unit per day requirement, we would say you would only have 150 units per year, but with a 4-unit cap per day, we would say 100 per year. I hope that makes sense. So we would recommend that we implement all 3 of the recommendations. The first step and the quickest step would be to have some requirements and review for the prior authorization process. We've actually already begun those discussions with DHS and DMS, and they've already talked with our prior authorization, the company that provides prior authorizations. We're looking to see what can be done there. We think there is some tightening that can occur. We'd like to do that before summer, see if we can avoid some of those spikes. So, wake up. Here's our, this is the to wake you up, $107 million over the course of
Actually, this is
3 years.
If you do steps 1.
Oh, this is just for step 1. So, what do we have here? Help me out.
Okay,
Got lost.
these were the potentials for all 3, the 3 specific fixes or all 3 recommendations. If we just fix one, if we went from $82.80 to $40 per recipient, if we had done that back in 2013, it would have saved over $40 million, just making that one change to the procedure code to reduce the amount to $10 per unit. And that would have been up to $13 million annually. If we had done 2, which alternative 2 was to have a 4-unit cap per day, that would have saved approximately $10 million per year in this one procedure code. If we had done 3, it would have saved around $23 million a year. But the big issue is this: if we do all 3, if we limit it to $40 a day, we limit it to 4 units per day, we put a cap on it of 100 units per year, then potential savings would have been over $35 million a year in this one RSPMI procedure code 90853, which these are real numbers from our claims in the last 3 years. It's really not a projection, but seeing that potential benefit if these changes were made in this program for this one procedure code is up to $35 million a year saved for the program in billing. And that was kind of what we asked Advanced Med to do, looking at the numbers and data to show what we could do. And that ties in with
Okay,
our
before, we got a few
recommendations.
questions here, and
Sure.
making all of those changes, if we did that, would that put us in line with what other states, or more aggressive, or less aggressive, or about where everybody else is?
We'd be about where everybody else is.
Okay, so it's not like we're doing something that's not done in all the other surrounding states,
That's correct.
and that would save $30 million a year moving forward
Right.
on this one code.
That's what we believe, and that's using the past, using the past numbers, applying those changes to the past numbers. So yes, we would expect that to be what you would see going forward.
Okay, Senator Elliott, you're recognized.
Thank you for anticipating my question. So did you come to these numbers just as a matter of looking at the data? Or did you also talk to providers in our state to see what the effect, just to go a little bit granular and find out what we're doing? And then, so I don't have to ask another question, is there any concern about the efficacy question I asked earlier? If we just do what the other states are doing and we don't know anything about their efficacy with their procedure, and I don't want anybody in this room to think I'm not all about saving some money, but there is something to be said too for understanding more the story behind the data is what I'm saying.
Right. I agree with you, and I agree we don't need to just come in and say, well, gosh, that program is too expensive, we're just not going to do it, and then all these people don't get taken care of. I mean, that's not the goal. But what we did see was that there was a large amount of money that we believe we can save. So we started by looking at it from an outlier perspective. We had a meeting with DMS in our office a few weeks ago, 2 weeks ago, I think, where we all sat down and talked about it. We looked at the payment improvement initiative that was filed in October of 2014 or brought up in 2014 that we were discussing a minute ago. And this is similar to what, they had a recommendation of a payment rate that was close to $40 a day. And so, they were already looking at that. They spent a lot of time working with the providers. I have not done that. I have not taken the time to do that because this has all happened very quickly.
They spent, who was the they? I'm sorry, I was trying to follow you.
Oh, DBHS. No,
Okay.
when DBHS created a payment improvement initiative, that's what it's called, I believe, October of 2014.
Okay.
It's called the Payment Improvement Initiative. And they did spend a lot of time working with providers to develop that. And no, I'm not here saying that I've not talked to providers, and I don't want anybody to think that I have. We came at this from a numbers perspective.
Right.
But we received this information from our contractor that CMS provides to us. And they have looked at this around other states. They work real closely with Medicare payments. They work real closely with Medicaid payments. And they're comparing Arkansas numbers to other states. And so that is the information I'm providing to you. I'm not telling you that I have talked to the providers and that they agree or that they think that this will be able to take care of the population. I'm not saying that. I'm saying the numbers show that savings can be had.
Is there somebody at the table who has talked to providers?
Well, Senator, if I can, I mean, actually, I think the answer is some of both, that the numbers are alarming enough. We need to make a fix on this.
Yeah.
But the $40 number that we had before was part of a package of reforms, and where it becomes an issue that you're pointing out, and Representative Hammer, you realize this, the Birch Tree communities, for example, that serves the very seriously mentally ill, people who otherwise would be in and out of the state hospital, they try to keep them stable at home. We wouldn't want to make a fix to this on these numbers without making sure for some of those more specialized providers that we don't drive them out of business inadvertently. So, I mean, we need to move aggressively, but we also have to be careful not to have some pretty serious unintended consequence that could affect public safety or really harm some people. And that's what we need to work on. But clearly, we've got to address this issue.
But you feel you can address you're going to address the issue by following up on, here are the numbers that are out of sorts, let's talk about this and see what the bottom line might be if we go down this road.
Yes, I would
So
say,
we'll be in- okay.
I'd say a combination, frankly, from our standpoint, it's a combination of what they're recommending,
Plus.
tempered or informed by, and what's the impact on the provider community, and more importantly, on some of the clients that I think we're all concerned about.
Fair enough. Thank you very much. Thanks, Mr. Chair.
Representative Hammer, you're recognized.
Thank you, Mr. Chair. Elizabeth, let me ask you, on the population you're talking about, are you talking about adult population? You talking about school-age kids that are receiving school-based therapy? This subject that we're having, which population are you talking about?
So this population covers both adults and children, and it is one specific billing code. It's the group therapy billing code 90856 that is provided for group sessions for either children or adults. The only change between children and adults is that you can only have 10 in a group if they're under 18, and you can have 12 in a group if they're over 18.
Right, and I'm familiar with the school-based side of that
Okay.
from the past, but I guess where I'm leading up to, I'm thinking about a discussion we had earlier today where we carved out the nursing home population for a specific reason, because we didn't want to throw the baby out with the wash, so to say.
Right.
But have you looked at, and I asked you this a while ago, but is there the possibility that in areas where there are specific needs, as Director Seelig mentioned a while ago, the possibility of carving out a population to make sure that we don't punish the areas that are kind of unique in the services that they offer, because we realize that there's a population over here that has taken advantage of the policies that are in place. And what have you seen in the other states, if you've looked at that at all?
Right, and we can look at, I think we can look at that, and I think we will work, I think that's the whole point, is this has come up very quickly. We knew we needed to find savings. When you find $110 million over the course of three years, over the course of 3 years, and we're looking at needing to get to an $835 million savings, if we can come up with a good portion of that with one billing code, that's kind of a start. And so what we'd like to do is work with DHS and make sure that this makes sense.
And I just quickly add, Representative Hammer, what we had proposed and what's in the Diamond Care Plan and what we'd expect managed care companies to do, we've all talked about tiers of care with the idea that the top tier would be the folks you're talking about. That's going to take more time, and the question is, can we do a quick fix on this that doesn't really harm somebody while we put what I think everybody agrees are more fundamental reforms that need to happen, but that are also more complicated?
Right, and I'll make it quick, Mr. Chair, but I just want to make sure, and I agree, there needs to be reform. I mean, it's the discussion nobody wants to have, but we have to have it because we're driven out of the need and evidence of the numbers, but at the same time, we want to make sure that the numbers aren't just the numbers that we're not going to see quality of care compromised either, but obviously your numbers support that there's room for that discussion to take place.
I agree.
Thank you.
Senator Stubblefield, you recognize.
Thank you, Mr. Chair. By the way, I think the number is 67% of the beneficiaries are under 18. Is that correct?
I don't.
67% of the beneficiaries of this program. Okay. By the way, under your recommendations, if we implemented what you're recommending, you said we would save $40 million. That would put us down to $110 million. These 6 other states, who I can't say for certain, but I'm quite sure they have larger populations in Arkansas. They still average 3.7 million. We're paying 110 versus 3.7. I think, Mr. Chairman, what I would say is we need to look very closely at what these other states are doing and then implement something along the same lines if we can save $140 million. Because I'm quite certain that these same providers are working in these other states. And I'm quite sure that these other states have larger populations than the state of Arkansas.
Well, again, that's what we're doing, and keep in mind, some of this is talking out over a 3-year period versus a 1-year period when you talk about the $147 million. But I agree, and that's the process that we've hired the Stephen Group, and they've worked with OMIG to try to identify all throughout Medicaid. We're going to probably find things like this, probably not many that are this glaring. But do we want to stop at 40 million if we can get 60 million? And as Senator Elliott said, not compromise services? Certainly not. And we will continue to look at that. And that's what we...
Well, I agree. I think it needs to be looked at very, very closely.
Representative Ferguson, you recognize.
Thank you. And I commend you for your work. I think you've confirmed what a lot of us have thought for a number of years that's been going on in behavioral health. I guess my question is, so we fixed this 90853 code. Are they just going to start coding with a different code? I mean, we found that in episodes of care that when we went to, when we included the ADHD, then they just started coding for dollars and moving it to ODD. So are we really going to resolve the problem by just correcting this one code?
Well, the goal is to solve the problem. And we have a prior authorization process, and we are working with DHS on that process to make sure that it's and that's where I think there's a couple of ways, if, like you said, that you don't want it to pop up somewhere else. And so, we have an auditing function, we have a review function that I'm charged to oversee reviewing that, but it's harder to chase the money after it's been paid. And so
Right.
what we want to do is make sure and look at it on the front end. We want to work on provider training. We want to make sure the providers understand what's going on and why this is happening. We want to make sure and look at those patient populations because we don't want to lose needed care. One thing that I believe is that there are likely patients who are receiving group psychotherapy that may not actually need it. And so that's something that we need to look at. We need to see if they are, is it an overutilization? I mean, the fact that everybody gets 6 units and that it goes on and on and on. There's no limit on how many you can have how many group psychotherapy sessions a person can have per year. Outcome measures. I think we can look at outcome measures through the prior authorization process. And so what we want to do is make sure that these patients are actually getting better. If they need group psychotherapy, they need to get better.
Sure, and I guess the process for us is it'll be a rules and regs, this would just be a rule change?
Right, that's correct.
We got the rules and regs?
That's correct.
Thank you.
Okay, we've got 2 more, and I'll just reemphasize that we've got 4 more items on the agenda, so if you're asking questions, you got to stay till the end of the meeting. Senator Ervin, you recognize?
Thank you, and I always do. Stay to the end of the meeting. So, no, they're just quick questions, and thank you, Mr. Seelig, for pointing out, because I think in the Diamond Care Plan, we did utilize a lot of what was recommended and suggested by DHS on that plan that did not go all the way through. So that is part of the Diamond Care Plan that we put forward as recommendations. But, to Mr. Representative Hammer's point, clearly there are other codes and there are other opportunities for usage, so that there are populations that won't get hurt by this. I think that needs to be looked at, but I think this is one code we're talking about, whereas, these folks are receiving all different kinds of services under, it's not just one client that you're talking about receiving one code of therapy here. They're receiving this plus other codes attributed to that one client. So that needs to be part of the calculation, because I just feel like I don't think we would be hurting any population by really addressing this problem. And I just wanted to say that because it's got to be a comprehensive look at that.
Thank you.
Thanks.
Senator Johnson.
I got a question on our dual eligibility compared to these other states that you looked at. It's phenomenally higher. Is there a reason for that? Is there a diagnostic that we're doing in Arkansas that is different than these other southern states? Please speak to that.
Okay, I don't have answers to why we are higher for the dual eligible, but I'm looking into that.
Thank you.
Any other questions on this item? John, do any of you guys anything to comment or say about that?
I think in terms of for Medicaid, the department, we are supportive, and I think have been working very closely with OMEG and Elizabeth and her team and the Stevens Group to dig into this issue. I do think we need to understand more about the children versus adults. I think coming back to the previous question, children are predominantly the larger population served through RSPMI. But when you look at a coding level, in some cases, particularly for some of these adults with severe and persistent mental illness, they may be utilizing a lot of those codes. And so I think it's just understanding more about kind of the children versus the adults. But that said, we are supportive, and I think want to continue to work with OMEG and team and drill down more into where we can start to make some of these changes in the short term, and also look at some of those longer term reform options.
Awesome. John, Stephen, do you have anything you would like to say about this before we go on to the next item?
Real brief, and I want Senator Stumpfield to hear this. This has been an issue that they have tried at DHS.
Go ahead and come on down there and.
This is an issue that DHS has tried to correct. There was a PCG report on rate review, complete comprehensive review around 2011. They ended up going forward. Those rate review rules changes were not passed through the legislative process. The really good thing here is that the task force was convened, put together to look at reforms, to look at areas. They were already looking at some of these things, but there's no way the expediency of this would happen today. And having the OMIG involved to buttress and to back up what Representative Gray had asked, the question and the things that are going on, it's a synergy happening that is good for the state, that you end up doing it the right way, and you do look at the impact on the potential changing of these rates as well. So I think you're going to start to see rule changes, and I would hope that you would really consider that, and you would not consider the special interests that are going to come forward over the interests of your taxpayers as well as the consumer. That's all.
Senator Stubblefield.
I just have a comment. Thank you, Mr. Chairman. I'm staying till the end of the meeting too. So, Louisiana caps their units at 40. Alabama caps their units at 12. And you're recommending Arkansas stay at 100. Am I correct?
So that, when you're looking at the stats, you've got to be careful and see, is their unit it's a session issue. So what we're looking at with this is they do vary from state to state, but it depends. Is a session a 60-minute session, a 15-minute session? If we stay at a 15-minute increment for a unit, then 1 hour before, and that's 25 sessions per year. Our research and review found that as a whole, that most RSPMI recipients are receiving 44 group therapy sessions per year, which is a lot. So if you had 25, then that would be bringing us down close to other states. Maybe we're still a high part. Now, one thing we did have to Senator Ervin is that there's a concern about the care and treatment, and you wouldn't want to cap a severe situation at 25, but that's part of the PA process, the prior authorization. We've got to make sure that our prior authorization vendor, Beacon, is doing a good job. And in the past, what they would do is just a person would get prior authorization for unlimited sessions. But if you tell them you're getting capped at 25, and you keep them to that, and if you need more, you come back and prove to us that it's working, the evidence-based, that it's helping, and we're having progress, maybe that would allow them to get the care they needed. You've got to have a better restriction, tighter review of your PA process, because, as you mentioned, we stopped this code, and there may be a potential to overutilize a different way. So it's all about the PA process.
Okay, and again, members, there have been a couple other ideas people have suggested. This will come before rules and regs, I expect too soon. The department has said they're going to bring something, and we'll have an opportunity to flesh it out there in more detail about unintended consequences and how's the best way to proceed forward here, and making sure that we are getting something in line with other states and that also provides the services. So anyway, I want to thank you all for working with the Stephen Group and for the outstanding job here of identifying this. And what I also appreciate is that, as Senator Elliott said, so many times we don't do the due diligence to make sure that there's not a reason why we're not comparing apples to apples and checking with the states and saying it's really $33 million. I appreciate that effort you put into it. Having said that, you are dismissed from the table, and I think it's time for our DRG group. So, Representative Farrar,
Thank you.
are you going to go down there?
Senator, can I just ask, did you want me to address the issue on the private option costs or deal with that later?
On the chart?
Well, yeah, on the chart. I mean,
I don't want to go into a lot of detail about it. I had a discussion with Director Seelig at lunch. Basically, they're going to revise that on both the top and the bottom. It's probably going to even be better news because there's some projection changes. Is that fair to say?
yes, sir. Well, and I guess in short, while there are more people on the private option somewhat than we anticipated, the cost per person is lower than we anticipated because we in Optimus were very conservative in our estimates of what it would cost. So the total, even while there's more people, the total cost of the private option is coming in quite a bit less than we had budgeted for.
So again, as we start talking about cost projections, we're going to look at both the top end and the expense savings end, however you want to.
And we'll bring new numbers
to
the Stephen Group.
Thank you. Representative Farrar, are you wanting to present from there? Is that what I'm seeing? You're going to have to snuggle up closer to the microphone then.
I mean, I meant that figuratively too, sorry. Well, thanks. I'd like to thank the Stevens Group for proposing this idea in their proposal, and especially with Mr. Palmer on his data collection on all this. We had a couple of meetings, 2 to be exact. We had all the hospitals, stakeholders, insurance companies on the first meeting, voicing their concerns. We also had 3M Corporation come down and give us a presentation on how we would set this DRG system up. Our last meeting today, we had, the stakeholders were here. I asked a question, did they have any problems pursuing this way? The Hospitals Association, Children's, and UAMS said they didn't have a problem with it as long as they had a seat at the table when they figured the base rates for the DRG system. So that will be up to the to DHS when they form that committee, but I'm pretty sure they will have a seat at the table. So what we did in committee today was we want to recommend that we put the AP-DRG system to a vote in March at the next meeting and see if we can get it through committee and proceed forward on this, on doing the DRG payment system for the Medicaid population for inpatient hospitals.
Senator Ingram, do you have anything to add?
You did a great job.
Okay. John, do you have anything to add from?
Thank you, I appreciate
Wow.
it.
Well, do you have what you need, John, to be able to put that into our packet of recommendations then that will, yep, perfect, okay.
And I'm not taking questions.
Well,
This is short.
it
This
might
is little-
surprise you to know that Senator Irvin has a question.
Oh, no, I'm not answering her question.
No, just, it's across the board, correct, with the hospitals? I
I'm
mean,
sorry?
it's across the board, including Children's, UAMS, y'all looked at all?
Yes,
that?
they were
Thank you.
they were at all, no,
Gotcha.
both our meetings, and when DHS forms their committee,
Yes.
they want a seat at the table, and that will
Okay.
be up to the DHS. when-
Okay,
when-
perfect. Thank you, appreciate that.
And I have a question from Representative Ferguson, Representative Gray, Representative Boyd, and Representative Douglas. None of you are recognized, unless you really want to be.
Thank you, I resign. I resign.
Okay, this is, just like committee, this is the time to run your stuff through. Okay, Sheila Cooper, we're going to talk about the EF progress, so if you want to come down. And John? Introduce our new member. Push your button there.
There we go. My name's Sheila Cooper, and I'm working with the Stevens Group. I spent 20 years in Texas Medicaid, 10 of those on the eligibility side, and now I'm in consulting, and I'm working with John.
Well,
So-
welcome. It's good to have you joining us.
Thank you. Just my role here is to provide contract monitoring for the EEF project and the Gartner work that's being done there. So today, just going to present an overview of what the current status is, and it's going to be mercifully short because they've just gotten started, basically. But just to update you that they have started the project number 6, which is the competitive procurement of the system integrator services. They've held a kickoff meeting, and the work on the requirements for the RFP has started. And the schedule has been published and appears to be on track. There were several other work streams, as y'all may remember from the Gartner report. There were 7 work streams. The one we just discussed was the big one that is the procurement. But there are also 6 others in addition to that one. So quick update on those other 6. The first was halting the Curum development, and that's that's been completed. Next was to define and ratify and promote the state's Health and Human Services vision, and they've established a committee, and they're on track to present their findings in mid-March. The next one was to develop strategic sourcing and vendor management capabilities to improve contracting. That's on track, and they've instituted quarterly vendor performance reports, and that is going and will be ongoing through June. Then the next was to define and implement architecture, vision, standards, and methodologies. So the technical documentation and standards are being documented. DHS feels good that they've got much of that technical documentation prepared and ready for the vendor library for the SI RFP. And the last one was to enhance communication and organizational change management processes. That is also on track. They're revising their charter and working with the IT Oversight Council that was workstream number 2. And that's it.
I just wanted to say that Sheila is going to be John's new contract expert. So we've had, Martha's been doing a great job with that, but we do a lot of things with contracts, and people do that outside of these meetings, so Sheila is the new contract expert.
Representative Hammer, you recognize.
Thank you, Mr. Chair. On the RFP that's due out, am I to understand, is that going to be for the systems integrator, what we've been calling this systems integrator, number 6?
Yes.
Okay. And, Mr. Chair, let me ask you, is that going to come through this committee to be reviewed and looked at, because that'll be close to the time that we're finishing, or is that